Well, welcome everyone to the Cardiology Marathon part of Med Study, but I promise you I will try to keep it as interesting as possible. So just a little bit about myself. Tony mentioned, I believe in the words of Gandhi, be the change you want to see in the world. So I'm a runner. I like to run. I've completed 13 marathons as well as the 10 by 10 challenge, which is running 10 miles every day for 10 consecutive days for 100 miles. And I challenge you all to set yourself a goal not only for passing the boards or whatever that may be, but also a physical goal, because it's important for your health, both mental and physical, to be at its optimal so you can perform best for yourselves, for your family, for your patients, etc. Okay, so we're going to be doing 5 segments today of cardiology, and each segment is going to be about 55 minutes. I'm going to try to give you a little bit of a 5-minute break after each lecture. So what was my board prep that I did? You can see I passed both the maintenance of certification in internal medicine and the cardiology med study. And to quote from the Matrix, Neo, sooner or later you're going to realize, just as I did, there's a difference between knowing the path and walking the path. Well, I have walked the path, just like you, many of you are walking the path. And my presentation does follow the template for the boards. So first of all, let me introduce myself. Who am I? Who am I? I am Dr. Star-Lord today, and you all are the guardians of the medical galaxy. And I have a plan. I have part of a plan. Our nemesis, the board exam. And as I mentioned, my content will directly reflect the ABIM contact. And I met someone in the elevator this morning, and they asked me this, and I will tell you all. First of all, due to traveling at turbo speed, we will not have time for questions during the presentation, but if you want to grab me during the breaks, that's okay. And to quote Rita, I will never let you down. And if you've enjoyed my presentation, I would be honored to receive a sweet feedback score. Okay, so let's start lecture 1. So here is what we're going to cover in this lecture. A little bit of imaging, x-rays, echo, some of the more advanced imaging, and then a little bit of physical exam at the end of the presentation. So firstly, chest x-rays. It's important. Chest x-rays are still an important part of internal medicine and cardiology. And hopefully you would recognize someone with this chest pain and a wide aortic knob here who is having an acute dissection, and someone who will live to see the morning, unlike our couple in this famous opera. So important, first of all, is what is normal in a chest x-ray. So you should be checking the chest x-ray and make sure you see certain things on the chest x-ray. For example, you want to make sure you see an aortic knob. If you don't see an aortic knob and you were to see notching, rib notching, you might be thinking, coarctation. You want to look at the size of the heart, the left atrium. Is it big, left ventricle, etc.? So it's important just to have an idea of what's normal. So let's take a look at a couple of abnormal chest x-rays. This is a 75-year-old male who presented with dyspnea and pedal edema, worse for the past 2 weeks. So take a look at his x-ray. Hopefully you can see some of those abnormalities. Let's take a look. This is a patient with severe heart failure, and you can see there the enlarged left ventricle with the cardiomegaly, the nice plump, juicy pulmonary vessels, and the pulmonary vascular redistribution. You can see large vessels toward the tops of the lungs, which you normally should not see. And then if you squint your eyes, you can see the curly B lines and a little pleural effusion there. This case is a 22-year-old end-stage renal disease male who had dyspnea over the past 2 months and missed multiple dialysis sessions. Came in really dyspneic, hypotense, and this is his x-ray. So this has something, the diagnosis or the kind of term for this has something to do with back in the day when we used to travel around via camel. We used to have to carry these with us for these long journeys. And so this is water bottle heart. And so this teaches you that not all enlarged cardio silhouettes are from heart failure. And especially if you have enlargement of the silhouette completely around the heart. So you can see the this on this side here, the right side and the left side. So this is an effusion on both. It's something surrounding the entire heart. And if you can squint your eyes, you can probably see where there is effusion and where there is heart there. And this is a classic pericardial effusion. This is a 45-year-old female with lymphoma, status post-mediastinal radiation. Comes in with peripheral edema, ascites, and hepatomegaly. And so remember, not only you're looking for things that might be missing on the x-ray or different, but you're looking for things that normally you shouldn't see. And hopefully you can see on the x-ray something that you don't normally see. And that something is calcification in the pericardium there. And this calcification you can see also on the CT scan, and this makes the diagnosis of constrictive pericarditis, aka skull heart. Okay, time for your first question. A 19-year-old male patient presents with high blood pressure. He's got a history of bicuspid aortic valve, and he's on metoprolol for the hypertension and hydrochlorothiazide. So his blood pressure, 200/90 in both upper extremities, and he's got an ejection click and a systolic murmur at the left sternal border. Also, another different systolic murmur is heard under the left clavicle. The radiofemoral artery pulse is delayed. No abdominal bruits are heard. And lab is normal. Here is the chest x-ray. So I want you to take a look at that chest x-ray. And, if you can also look in your books too, you might be able to, and take a look at that. Hypertension, what do you think might be going on in this case? And a little bit of a hint, something that we normally see on the silhouette we don't see in this case. So what is the likely cause of the hypertension? Essential hypertension, coarctation of the aorta, renovascular hypertension, or tetralogy of Fallot. I hear your clickers clicking away. Wow, 94% at 8 a.m. in the morning, fantastic. So hopefully most of you, essential hypertension is kind of pretty unusual, rare in a 19-year-old. And tetralogy of Fallot, he does not have a boot-shaped heart, but he does have signs of coarctation of the aorta. And first one is he had a bicuspid aortic valve, because 70% of people with coarctation have a bicuspid aortic valve. He had high blood pressure. He also had, and I've got his x-ray up there for you, he doesn't have an aortic knob there. You normally should see a nice little juicy aortic knob, and the reason he doesn't have it is because it's not there. And it's not there because instead he's got a narrowing or coarctation there. And secondly, he has the rib notching. You can see, hopefully, if you look under those ribs, you can see those little bumps. And that is caused because you have problem with blood flow from going through the usual aorta to the lower part of the body. The body says, hey, let's use some other arteries because we need to get that blood still from the top down. And so it uses some arteries off the branch of the aorta before the coarctation. And some of these artery branches go down in front and behind the ribs. And so from birth, those arteries are carrying more blood, they're bigger, more juicier, and they actually cause the indentation as the ribs grow. Also, you can sometimes see a pre and a post dilatation on the arch. So for example, here we call it the figure 3 sign. Remember to check the brain out because coarced patients, birds of a feather flock together. They have the bicuspid aortic valve. They also can have baryaneurysms in the brain. So take a look out for that. If you have a Turner syndrome, always think about your coarced and bicuspid. And then finally, when to do surgery or to stent them. We can stent them these days. If their peak-to-peak gradient is over 20, if they have hypertension or heart failure. So this individual would be referred to get this coarctation fixed. Let's now move on to our bread and butter transthoracic echocardiography that we do, echoes that we do pretty much on a daily basis. So what are the indications for transthoracic echocardiography? Cardiac structure and function, pretty straightforward. Arrhythmias, high blood pressure, as well as in the acute setting if they are hemodynamically unstable. Valvular function. If someone has a murmur, for example, that's a loud murmur and it's late, it's not a innocent sounding murmur, we want to make sure we get on top of that. Maybe they've had an embolus and we're looking in the heart to see is there any cardiac source of embolus. Aortic disease, so someone with Marfan's, if we are suspecting that they might have Marfan's and we want to take a look at the heart, look at that aorta in particular. Hypertension, heart failure, or cardiomyopathy. And then finally, someone with a fixed split S2 that you are hearing and you're thinking, maybe they have an ASD and we want to take a look with their echo. And here is such a patient that you can see here with an ASD there. Here is someone with a VSD who had a hemodynamically unstable as examples. Now, just as important of knowing when you should do the transthoracic is when you should not do it. What I call the just don't do it, the anti-Nike. And I like has anyone read Born to Run, the book, or listened to that? Got a couple of hands there, awesome. It's a great book on, sort of tells the history a little bit of the running, and also there's a guy in there called Barefoot Ted who is anti-shoes, and he started the whole barefoot kind of movement, and he's very anti-Nike. So anyway, who should you not order an echo on? Well, let's say you have someone who has a classic innocent sounding murmur that comes into your office, especially if they're younger and healthier. So a 1 to 2/6, well localized, systolic mid-peaking at the left sternal border. I mean, that's a classic RVOT or PA flow murmur, particularly in a younger person that is thin. Or in a lady that is lactating and you can hear a venous hum over the breast. That's a mammary souffle. So you don't want to, get an echo on them. And you don't want to get an echo every time you are seeing your heart failure patient in your office. However, if there is a clinical change, so if someone comes into the hospital and is admitted with acute decompensated heart failure, absolutely get that echo because there might be something new going on that is contributing to that decompensation. And then finally, valvular disease. This is the one that the boards like to ask a lot about. And, in terms of should you just follow them clinically next year or should you follow them clinically and get an echo? The main thing to know is for mild valvular disease, so your mild mitral regurg or your mild aortic stenosis, you don't have to do an echo annually. In fact, the guidelines say every 3 years or if there is a significant clinical change. So your physical is okay. If you have moderate or severe, it's okay, and very reasonable to do an annual echo to check for changes because, at some point they will or may need to go to surgery. Okay, let's now move on to transesophageal echocardiography. So this is, the main things to remember about this is it's better resolution. So regular echocardiograms are about 3 millimeters, 4 millimeters resolution. Transesophageal is 1 to 2 millimeters resolution. So in other words, we can see smaller things, tricky things to see better. So what are the main indications? Well, if you want to see cardiac structure or aortic structure and function, and you're not getting good images with the regular transthoracic echo, or if you're suspecting maybe someone with endocarditis, and it's endocarditis, and then all of a sudden they develop a complete heart block or a first-degree heart block, and you're thinking, maybe they've developed an abscess, and the infection's not getting better. So you can do a transesophageal echocardiogram, and hopefully you can see on this image here. Here's a transesophageal echocardiogram. Here's an aortic valve vegetation. Here is an abscess here, up here outside the aortic valve. Also, intraoperatively these days, we're pretty much doing a lot of, anesthesia does a lot of transesophageal echo on pretty much most of the cardiac cases. It can really help them to manage the cases and to get better outcomes. Transcatheter in particular, especially transcatheter. So TAVRs now, MitraClip, etc. And then finally, you might have a patient who is critically ill and they might have been in an accident, they're on the ventilator and you can't get good images, they might have bandages, etc. And you want to get some information about the heart because it's really important to make decisions for them. That's when a transesophageal echocardiogram in the unit, for example, is a great idea. And here is just an example of a mid-esophageal view, just to show, so you can see the esophagus here in yellow and the aorta and the heart. So this is where the probe goes down into the stomach. We start with transgastric views, and then we pull the probe up, lower, mid, and then upper esophageal views. And here's an example of a mid-esophageal view showing the left atrium, right ventricle, and left ventricle, and the anterior septal on the right side of the tricuspid valve, and then anterior and posterior on the mitral valve there. Let's now talk about stress tests. And it's important not to stress out about cardiac stress tests. They are best if you have intermediate probability. So for the person that has the family history, has the exertional angina, classic story, has the risk factors and all of that, and it's gotten worse, and now it's happening, with minimal exertional rest, that's a slam dunk, cath lab. On the other hand, if you have a person that tells you that they work out, they never get exercise on exertion, but they always get it when they drink down their ice-cold soda or their ice-cold water, afterwards, and that's when they get the pain. But never with exertion, then you'll be thinking of something else, like diffuse esophageal spasm, for example. So we're okay with those groups, but the intermediate group is a big chunk of patients. And so who are those people? Well, if you've got someone who's younger, that doesn't have a lot in the way of risk factors, but the story sounds pretty good, and you're kind of concerned, or if you've got an older person that has atypical pain. And remember that women, the stress tests are lower sensitivity and specificity. So we normally start off with the exercise treadmill test, no imaging, also known as exercise electrocardiography. And that will give us a good indication if if their chest pain is related to ischemia. It's pretty good. Sensitivity about 65%, specificity 75%. So in other words, if you've got a chest pain patient and they have a pretty normal ECG to begin with, and they can exercise, this is a pretty good test to start with. They have to be able to achieve a reasonable degree, 85% maximum predicted heart rate. So let's take a look at some other high-risk findings that you should be aware of on the exercise treadmill test. If they can't exercise very long, less than 4 minutes, for example, if they have a really low peak systolic blood pressure, if they get angina during the test, or if they have significant ST depression, especially if it happens early at a low rate pressure product. Early onset as well, if it happens in stage 1. If they have ST elevation, and then finally, if they get bad ventricular arrhythmias like couplets or runs, that also is an indication of ischemia. And then if their heart rate doesn't come back to normal fairly quickly, that's also badness. So let's take a look at a person who came in, ruled out, and they can exercise, a younger person with not much in the way of risk factors, but a good story. So here is their baseline ECG, and we put them on the treadmill, and we were looking for change. Positive test, at least 1 millimeter of downsloping ST depression in 2 contiguous leads. And hopefully you can see on that ECG, lots of changes going on. So let's take a question. A 53-year-old woman presents to the emergency department with burning substernal chest pain without clear precipitating factors. So some history of smoking, hypertension, and is on lisinopril. You rule her out and the EKG remains normal. So you order an exercise treadmill test and she exercises for only 3 minutes, not long, and only gets a heart rate up to 110 and has her typical pain. So here are her ECGs. Here's her resting ECG, and there is her peak exercise ECG. Okay, so my question is, what should we do next to this lady? So early onset, something going on in the ECG, chest pain, what would you like to do next for her? Would you like to reassure the patient and say everything's cool? Repeat with nuke. Just put her on some secondary prevention or coronary angiography. And the clickers are off. Wow, awesome. So she had a very positive stress test, as you can see if you review later. Early onset, reproduced her pain, significant ECG changes at a low heart rate and blood pressure. The next step for her, this is a flunk, an absolute flunk. The next step for her is to go to coronary angiography. Some of you chose the nuclear perfusion. There's no need to do that. I mean, if you have a clear positive stress test like this, you know it's there. The nuke is going to be positive, and just in case you didn't know, the nuclear test runs about $3,000 to $5,000. Cardiac catheterization, coronary angiography, it runs about $1,500 to $3,000. So you don't want to be giving added expense. So you don't need that in this case. It's a clear answer. And then finally, the secondary prevention, she's already on good blood pressure control, etc. She's having this chest pain with minimal exertion. This is someone you can't sit on. You need to get them to the cath lab. So what about cardiac stress tests and imaging? So this is the next level. As I told you, the exercise treadmill is where we like to start, but in some people, we have to do some imaging modality. And we have a couple of options for that imaging. We can do nuclear or we can do echo. So who should we send for a stress test with imaging? Well, first of all, if they cannot get on the treadmill. So we can't do a routine exercise treadmill test. There are some people that can't. Might be that they have a walker or they have amputations or that they tell you that they just are unsteady. They can't do it. So that's number one. And secondly, there are certain abnormalities on the ECG that preclude us from doing a regular exercise treadmill. In other words, the exercise treadmill test will no longer work if they have, and there are 4 classic ECG abnormalities that will fall into this category. That if you see a patient with this, you got to say to yourself, that's a classic abnormal ECG. I can't order an exercise treadmill. I need to go to imaging. So let's go over those really quickly. So which side am I standing on here of your side? Left. Okay, first one, left bundle branch block is the first one, which you can see there. Okay, and let me give you, see if we can get the next one. Okay, what am I doing now? Oh, gee, can't believe those people at the airport, I mean, they were just like, pacing, yes, pacing. So paced rhythm is the next one. And hopefully you will notice on these ECGs that their ST segments often are kind of messed up. And that's part of the reason why the regular plain old routine exercise treadmill test is not going to work. Okay, so that is paced rhythm. Now, what am I? Okay, I'll give you a hint. I have 4 legs, arms and legs, and I make this sound. Yes, the wolf. Yes, excellent. Okay, the Wolff-Parkinson-White pattern. If you have a Wolff-Parkinson patient, you have to do an imaging if you're looking to rule out coronary artery disease on them. And then finally, let's see. Oh, this has been a very entertaining lecture, and you guys have done a great job, so I think it's time for... what am I doing now? Resting. Very good. So resting, ECG changes. So if your ECG at rest, when you do your ECG on that person, already has ST depression on it, then the exercise treadmill is going to be useless, because remember, we're looking for on the exercise treadmill, a positive test is where normal and then depression with exercise and chest pain. So if they've already got the ST depression, then we can't do that test. Okay, so those are the 4 classic. There are a couple of relative indications as well, but those are the 4 ones just to know you need to do an imaging test. So we can do myocardial perfusion imaging, also known as nuclear stress test. And in that case, the stress is either treadmill or dobutamine and atropine. And we are looking, so that's stress number 1. In other words, we can get the heart working harder, pumping harder, faster, or we can do what's called regional hypoperfusion, which is where we actually give them these agents. They're very powerful coronary vasodilators. So normal artery will pop open and get good blood flow. Artery that has a stenosis can't change, so its blood flow doesn't change. And so what we'll see is at rest, oftentimes there's enough blood flow getting to the different parts of the heart, but then during stress, less blood flow is getting to that through the bad artery, so that muscle is going to, suffer, and good blood flow is getting to the normal artery, and we can see that difference on the nuclear. And if you see either hypokinesis on the nuclear test, or if you see where the technetium, or whichever agent you're using, if it is not getting to a certain part, it typically will be darker, it won't be as bright. So if you see those changes between the stress and the rest, that generally will be a positive nuclear test. And the next step then should be most likely to get a cath. We can also do stress echocardiography. And in this case, what we do is we actually get the heart working harder. So we do an echo, look at the contractility, and then we speed up the heart, either treadmill or using dobutamine and atropine, get the heart working a lot harder. And what we will note on the echo is the ischemic heart will get weaker. The muscle just can't pump as well, and so it doesn't thicken as much and it doesn't come in as much. And we can see that hypokinesis on the echo. And importantly, if they have the hypokinesis to begin with, and at rest and stress, that generally means that's an infarcted area. But if it's normal at rest and at stress, it gets hypokinetic. That generally means you've got a significant lesion in the artery that is supplying that territory. Okay, question 3. A 56-year-old male patient with hypertension presents with chest pain on moderate exertion. For example, when he jogs up several flights of stairs. He's a delivery driver and walks about 2 miles a day. You rule out MI, and enzymes are all negative. So his ECG shows LVH with repolarization abnormality and 1 to 2 millimeters ST depression in the lateral leads. So this is his resting ECG. And you want to order a stress test to risk stratify him further. So the question is, based on his resting ECG, what stress test do you want to order? Do you want to order a regular exercise treadmill test, an exercise test with imaging, ST segment Holter, or cardiac MR? So what would you like to order in this case to evaluate for coronary disease? All right, yes, you guys got it. He had what on his ECG, baseline ECG? Resting, yes, resting ST depression. So that means number 1 is out. We can't do the regular exercise treadmill test because we can't see that happen. It's already there at baseline. Cardiac MR, we're not there yet for coronary artery disease, and this is not considered a screening test for coronary artery disease at this time. So the exercise test with imaging is the way to go here. Okay, now let's go over the rainbow and talk about some more sophisticated cardiology tests, including catheterization, etc. So cardiac catheterization, we also sometimes call it the left heart catheterization, because we go up and we put a little tube and put some dye on the left side and we actually go into the aorta and find the coronary arteries and put dye in. We typically do it, one of the common cases we do it is someone coming in with a STEMI, or a heart attack. And you can see on this picture that there is a complete occlusion on the left there of the left anterior descending, which was successfully stented. So we do it for that, but we also do it for in other cases as well, which we'll talk about. And those are, if someone's on maximal medical therapy and they're still having angina that is progressing or that is just not, interfering with their daily activities, or they flunk a stress test, like they have a high-risk findings, like on that lady in the question we had earlier. Now, remember, all contraindications are relative, and mortality is pretty good. We typically quote people less than 1 in 1,000 chance of dying during the test. Morbidity, on the other hand, is, it's a little bit higher. So you do have to make sure you mention that. They can get a hematoma, hemorrhage, myocardial infarction, a CVA. It can turn into an emergency bypass, femoral artery pseudoaneurysm, arteriovenous fistula. And at that top picture, hopefully you can see this is newly minted July fellow in cardiology going in and with a catheter and nicely going both through the vein and the artery and creating a beautiful arteriovenous fistula. Arrhythmias, allergic reactions, as well as occasionally dissection, cholesterol emboli syndrome, retroperitoneal bleeding. And so in this case, the catheter has perforated the aorta. Here is normal position kidney. Here is kidney going into outer space because of this big retroperitoneal hemorrhage. And they'll often have the hemorrhage will spread into superficial layers of the skin, and you can get this, what we call the gray Turner sign. And then finally, renal dysfunction, infection, and thrombosis. And the cholesterol embolization syndrome, just think about it. We're going up that aorta, and in someone with oftentimes with vascular disease with a little wire or tube, and the inside of their aorta looks like a pizza. No, a 4-cheese pizza oftentimes. And we're going around, scraping around. I mean, it's not unexpected that some of that little cholesterol plaques and stuff are going to bump off. And so it happens. And they sometimes will get a kind of a systemic type syndrome. The key things to look for on the boards are they may say that they have red, purple, or blue toes. Livido reticularis, which is this kind of lace-like pattern you can see on this feet here. Hollenhorst plaques. So Hollenhorst was a dude, an ophthalmologist, I think, and he named this little cholesterol emboli, which you can see here in the retina. So this is a little bit of cholesterol that went up to the retina. That's a Hollenhorst plaque. Here's another plaque which went to the kidney, and they can also often get leukocytosis as well, and eosinophilia. So just be aware of this. Okay, now let's talk about cardiac CT angiography. So let's give radiology a call and see if we can get a CT today. Hello, radiology. How can we improve your image today? Dr. Star-Lord here, radiology. I got a dude in here. His name's Mr. Big Mac. He's a 350-pounder. He's came in with an exacerbation of asthma and AFib. His rate right now is about 150 per minute. Did I tell you? Something's happened to his kidneys. His creatinine's 5. Can I send him down for a cardiac CT? Why, certainly not. So remember, for a cardiac CT, we are going to be giving IV contrast. We need the person to have a steady and slow heart rate under 60 and regular. They have to lay on the machine and hold their breath, oftentimes for 15 seconds. So it's a good test, but again, you have to have the right patient. Cardiac CT is being used more and more now in emergency rooms because, as you all know, getting a stress test, especially a nuclear stress test, at 2 a.m. in the morning is not doable in most hospitals. So a lot of the hospitals now are using cardiac CT or calcium scoring on these patients that come in, especially in that intermediate group, to re-stratify them. And it's pretty good now. You can see there the sensitivity, 95 to 99% for coronary disease. So if you get someone in the middle of the night, they rule out, and they do a cardiac CTA and there's no calcium, you pretty much can be comfortable about sending that person home and having them follow up, with their PCP or their GI person. Here is an older male with atypical pain who came in, ruled out, and you can see the cardiac CT showed nicely there a proximal significant and a medium lesion, which was confirmed on coronary angiography, and he received a stent. It's also good for, CT is also good for other things, for example, masses, etc. The other option is to do what's called coronary artery calcium scoring, or CACS. The benefit of this is we don't have to give contrast. So someone with an elevated creatinine can still have a CACS scan, but we're still using radiation. So if there's any suspicion that there's pregnancy involved, it is contraindicated. Again, someone coming in with an intermediate risk, with a kind of a intermediate risk patient, not clear cut, it's reasonably good. It's not for asymptomatic patients. This is only someone who's coming in with some type of coronary presentation. The good news is, if it's zero, again, there's no calcium, you can send them home relatively safely. If any calcium, then all bets are off. You need to bring them in and do your regular rule out. And the higher the calcium, the higher the chance of disease. So especially a calcium score over 400, very high risk for coronary disease. And this is an example of an elderly person who came in, and you can see they had, in fact, calcium was detected in all arteries. They had an Agatston score of 2,111 and ended up having to go to bypass surgery. Now, cardiac magnetic resonance imaging, it's good for everything but coronary artery disease. So fantastic for congenital, fantastic for infiltrative disease, fantastic for masses. In fact, we can even tell you with pretty excellent accuracy what the tissue is, because they can do tissue typing. So, for example, here is a 66-year-old who came in with dyspnea and palpitations. The echo showed some mass, and they weren't sure, wasn't good images. They did the MR, and it showed the classic signs of a left atrial myxoma here, which was resected and proven. Very good for LV-RV mass and function. One thing, main thing to remember with the cardiac MR, we're using this special contrast agent called gadolinium, and you don't want to give it to anyone who has severe renal insufficiency. They can get this almost like a systemic sclerosis develop, and it's irreversible. So that's kind of not good, so we don't want to do that. While we were talking about myxomas, let's move on to the tumors. So the good news is here, most of them are benign. 3/4 of your cardiac tumors are going to be benign, and the commonest, of course, is the left atrial myxoma. Remember, left atrial mass, likely to be a myxoma. Papillary fibroelastomas, which are these little cheerleader-type fronds here, which you can see, and they're often on the on top of the aortic valve here, but they can be in other valves. And finally, atrial septal lipomas, which is just like little fat in the atrial septum. So they're the commonest benign. The 1 in 4 will be malignant. And remember now, right atrium and angiosarcoma. So this is the common tumor that you can see as a primary cardiac tumor. So again, these are fairly uncommon. Much more common, of course, are the secondary tumors. And just to remember which are the common ones, A, B, C, air for lung, B for breast, are the commonest cause of cardiac Mets. And they can present literally with anything. I mean, with chest pain, with dyspnea, whatever. We normally start with the regular echo. As I said, there's good news and bad news here. The good news is most of them are going to be benign. The bad news is, even though they're benign, they're not normal tissue, and so little blood clots can form on them, and they move around a lot, and they can break off and cause a stroke. So most of the time, we still have to take them out, the myxomas and the papillary fibroblastomas, for example, because we want to reduce that risk of them having a stroke. And if we can't, if they refuse surgery, then you need to put them on some sort of anticoagulation, antiplatelet to reduce that risk. Let's now switch over to right heart catheterization. So this is where we put a catheter into the right side of the heart, and most of the time we're measuring pressures here. Starting at the right side here, the right atrial pressure and central venous pressure, typically it's very low, almost 0 or just over 0, 0 to 6. And this is what I call the rule of sixes. Hopefully this will help you to remember the numbers. So 0 to 6 for the right atrial pressure, central venous pressure. If it's real low, super low, think shock or hypovolemic or septic shock. If it's real high, think cardiogenic shock, cardiac tamponade, or constricted pericarditis. Then moving on to the right ventricle and the PA pressure, typically systolic 12 to 30 over 6 to 12. Then moving to the left side, the left atrial pressure typically is about 6 to 12. And importantly, the left atrial pressure is about 2 to 1 ratio with the right atrial pressure. So the pressures do normally step up when you go to the left side of the heart. The cardiac index is usually 2.4 to 4.2. Again, those are divisible by 6 liters per minute per meter squared, and then you have your normal systemic blood pressure. So let's look at a couple of cases. Here is a 22-year-old end-stage renal disease. In fact, this was the guy that I showed you the x-ray of earlier. So he came in, he is hypotense, you can see. Cardiac index is still okay, but he's got elevated pressures there in right atrium, the CVP, the right ventricle, and the left atrial, all elevated. But there's something very funky about those pressures. And hopefully you can see that. And the funky thing is that he's got diastolic pressure equalization. Hello. Do you see it? Okay, so you can see here, 18, 18, 18. You normally don't have these pressures equal, especially on different sides of the heart. When you see that, you should think of two things only: cardiac tamponade or constricted pericarditis. In other words, there is some pressure around the heart which is causing the diastolic pressure to stay the same and elevated throughout the heart. And this is classic cardiac tamponade in this case, because we know he didn't do dialysis, so he got fluid built up around the heart. This case is a 66-year-old man with hypertension, diabetes, and cholesterol with severe chest pain for 4 hours, diaphoresis, nausea, vomiting, and lightheadedness. So let's take a look. Okay, he's got bad, low blood pressure, 70 over 50. Cardiac index, abnormally low. His pressures are elevated, but he does still maintain the 2 to 1 ratio, and it's not diastolic pressure equalization, so we know it's not tamponade or constricted pericarditis. But with the story and the risk factors, he is in fact having a big heart attack, and he's got biventricular failure with cardiogenic shock. You can see the classic, he's got the classic numbers, a cardiac index less than 2.2 and a wedge over 15. These are consistent with cardiogenic shock. Okay, now let's talk about the physical exam. And, sometimes you guys will get to the physical exam questions on the boards and it'll be like Panic at the Disco. But I'm telling you, you can be victorious if you know a couple of key pieces of information. So firstly, the physiologically split S2. So this is normal. So if you take a deep breath in and there's more blood on the right side, the right ventricle, remember the P2 is made up of A2 and P2. A2 comes first normally, and then P2 comes second. So if there is more blood during inspiration on the right side and less blood on the left side, what that means is that A2, the closure of the aortic valve, is going to happen earlier because there's not as much blood on the left side, and P2, which is the closure of the pulmonary valve on the right side, is going to happen a little bit later because there's more blood to come out of the pulmonary valve. So this is normal. Have a listen to yourself later if you or when you get back. Normally, you should hear lub-dub, and if you take a deep breath in and hold it, you should hear lub-da-dub, and then breathe out lub-dub. So that's normal. What is not normal is if you hear lub-da-dub the whole time, and when you take a deep breath in, it does also get wider. Lub-dub, lub-da-dub, and then breathe out lub-da-dub, lub-da-dub. That's what we call a widely split S2. So it's split the whole time, but it still varies physiologically. And this can be seen either early closure of the aortic valve for some reason. For example, someone with severe mitral regurgitation. Less blood is going to come out over the aortic valve, more is going to go backwards over the mitral valve, so the aortic valve is going to close earlier. Or if you've got someone who has pulmonary stenosis or some other pulmonary high pressure, so that it's going to be harder for the blood to be pumped out on the right side and for the pulmonary valve to close, so it's going to be delayed. So let's have a question on this. Physical exam. A 43-year-old woman reports dyspnea for 6 months. Echo shows severe mitral regurgitation and pulmonary hypertension. So what would you expect to hear on auscultation of her second heart sound? A normally split, a widely split, a paradoxically split, or a fixed split second heart sound. So severe MR, pulmonary hypertension, what do you think you would hear on her heart sounds? Excellent. You guys are on it, so she should have a widely split second heart sound. Now, she wouldn't have a paradoxically split second heart sound. Paradoxically split means that everything's backward. So your aortic valve, instead of being aorta first and pulmonary second, it's the other way around. Pulmonary first and aortic second. We typically see that with a left monobranch block, which she didn't have. And fixed split is a special type of split where it doesn't vary, the timing does not vary with respiration, and here is the main cause of a fixed split S2. So just think fast as a flash. So fast, fixed split, AS for ASD 2. So fixed split, ASD, second heart sound. This is the commonest cause of a fixed split S2, ASD. And you can find other things that can help you to nail down ASD. Some of those other things include sometimes you'll hear a pulmonary flow murmur in those individuals. Also their ECG with the commonest type of atrial septal defect, which is ostium secundum, often shows a right bundle branch block or incomplete right bundle branch block and right axis deviation. So they're classic. And generally we will fix these if they have a big shunt, so greater than 2-to-1 shunt, or symptoms, or if they have a big RV without signs of pulmonary arterial hypertension. We will generally close them. Okay, next question. An 18-year-old female from Honduras says that she has had a murmur since birth, and she was told by her doctor that she had a hole in the heart. You detect a split second heart sound that does not vary with respiration. There is a 3/6 systolic flow murmur in the pulmonary area, and the ECG shows right axis deviation and a right monobranch block. So what do you think is going on here with this lady? Is it mitral stenosis, aortic coarctation, an atrial septal defect, mitral regurg, or hypertrophic cardiomyopathy? So she's got a split second heart sound that does not vary with respiration, and she's got some changes on the ECG. What do you think is the diagnosis here? Wow, 99%. We are almost there, guys and girls. We are 1% away. Okay, so fixed splitting of a second heart sound you would not see with mitral stenosis. You would also see other signs with mitral stenosis, which we'll be talking about later, including a diastolic opening snap and a rumble, which she does not have. Now, her doc, believe the docs. I mean, have some skepticism, but, often in the, particularly where they don't have a lot of imaging, they are pretty good with their physical exam. And he told her that she had a whole heart. He was right. She does have a hole, and that particular hole is an atrial septal defect. Okay, let's talk about the S3. S3 is an early diastolic sound. So you hear lup-da-da, lup-da-da, lup-da-da. It's the sudden termination of early rapid filling into a stiff, dysfunctional ventricle, or it may be related to the tensing of the chordae, kind of like a bass guitar, brum, brum. So this is S3. So the left-sided one is the one we're most often interested in. You can hear it when they're at the apex with the bell. Remember, you want to use the bell. And remember, you want to do it, watch their breathing when the breathing goes down. So, when they're expiring, expiration. When they're expiration, that's when you will hear the left side because there's more blood on the left side during expiration. So this is when you'll hear it. The classic ones that you will hear it in are heart failure, reduced ejection fraction, as well as these high flow states like AR, TR, MR, VSD, ASD, and PDA. You can also hear it physiologically. So just looking out in the audience, it looks like most of you all are under 40. I could hear it physiologically in you, or if you were pregnant as well, and there's some other causes there. Valsalva. So sometimes the boards will say, give you a person with a murmur, and they'll say, as a board-certified internist who is very excellent at physical exam, you perform a Valsalva maneuver, and you notice that the murmur increases during the strain phase of the Valsalva. What is going on? And so remember, murmurs that get louder during the strain phase of the Valsalva include mitral valve prolapse and hypertrophic cardiomyopathy. They're the two classic ones that will get much louder during the strain phase of the Valsalva. And Valsalva is one mechanism to do it. You can also do it with nitrates or standing. Essentially what they do is they reduce preload, and that reduces LV volume, and that increases the amount of obstruction in these particular cases. And hand grip, murmurs that will be louder with hand grip include, my little mnemonic here, MAV's hand grip is loud. So M for mitral regurg, mitral valve prolapse, A for aortic regurgitation, V for VSD are loud. So with the hand grip, they will be louder. And the reason for that is the hand grip increases the cardiac output and peripheral resistance, which will increase the flow across these murmurs, across these particular vessels and lesions, and this will increase the loudness of the murmur. Elevated jugular venous pressure. Remember, we're talking about the internal jugular vein here, but in all honesty, most of the time, if they have elevated pressures, the external and the internal are going to be up. And just remember, other than heart failure, which is the commonest thing, there is a differential for elevated jugular venous pressure, which is given there. Canon A waves. So these are these huge, big bumps that you see in the neck. And these Canon A waves indicate AV dissociation. In other words, what's happening at the exact time you see a Canon A wave is that the right atrium and the right ventricle are both contracting at the same time. Of course, the right ventricle always wins. It's stronger, bigger muscle. So no blood goes across the tricuspid valve. It stays closed. And instead, when the right atrium contracts, the blood goes up superior and down the inferior vena cava, and you see these huge, big, what are called A waves. And so you see these classically with ventricular tachycardia, with third-degree AV block, and with ventricular pacing. Now, finally, let's talk about pulsus paradoxus. So everyone have a quick feel of your pulse there. Remember, underneath your thumb, and use your fingers, not your thumb. You'll get a good reading. So everyone's feeling your pulse now. Now, what I want you to do is take a deep breath in and hold it. And about now, you should feel your pulse getting a little bit faster and a little bit weaker. Remember, you've got more blood on the right side, less on the left. And then breathe out. And hopefully your nice, strong pulse return to normal. So there is a normal amount of drop in pressure when you take a breathe in. There's a little bit of variation, typically, 2-3 millimeters, not 10 millimeters. If it's 10 millimeters, in other words, an inspiratory fall in systolic blood pressure of 10 millimeters or more, this is what we call pulsus paradoxus. And my little mnemonic to help you here is the car-driving cat. So cardiac tamponade, constricted pericarditis, asthma, and tension pneumothorax. Those are the commonest causes of pulsus paradoxus. So question 6. Moments after a temporary transvenous pacemaker was placed into the right ventricle of a 50-year-old male with complete heart block, he developed hypotension, chest pain, and elevated neck veins. Heart sounds become muffled, but lung fields are clear. You note an inspiratory fall in systolic blood pressure of 15 millimeters mercury. So what do you think the echo will show? An ASD, acute mitral regurg, hypertrophic cardiomyopathy, and cardiac tamponade. Remember, you've just stuffed this hard wire into the right ventricle, jamming a pacemaker in, and all of a sudden he's become hypertense and he's got maybe pulsus paradoxus. What do you think might be going on here? Right on. Okay, so cardiac tamponade, yes. He's got all the signs of cardiac tamponade. The heart sounds muffled. He does not have hypertrophic cardiomyopathy. that would show different things on the in the neck veins, etc., and also physical exam. He also does not have an atrial septal defect. There's no mention of a fixed split S2 or pulmonary flow murmurs. Okay, good. Okay, we're going to get started with lecture 2. This lecture we're going to be talking about acute coronary syndromes. This is kind of like the person presenting with the acute coronary syndrome, a common thing that you will be asked about on boards. As well, we're going to talk about the stable ischemic heart disease and hyperlipidemia. So the acute coronary syndrome, I think you're fairly familiar with that. We've got someone who has developed a plaque. You can see there in the top diagram, you've got plaque developing, and then you've got in the lower diagram plaque rupture, and they get either partial or complete occlusion, which causes the supply-demand imbalance and their chest pain. So what are some of the signs and symptoms of acute coronary syndrome? I think you guys and girls are familiar with the common ones. Be aware that elderly diabetics and women can present with funky symptoms, including just shortness of breath or dyspnea, heart failure, confusion, fatigue, and nausea. So take those seriously. Also, important to know the quote-unquote new risk factors that have been added to the risk factors that probably you're aware of. So now these are official coronary artery disease risk factors. Preeclampsia, pregnancy-induced hypertension, gestational diabetes, systemic autoimmune collagen vascular disease, especially lupus or rheumatoid, double the risk. HIV, double the risk. Chronic kidney disease as well. So be aware those are risk factors and you need to ask about them now. So what do you want to do when they first hit the ED? In that first 10 minutes, you want to get them to chew on this, give them an aspirin, stick them, get the ECG, chat them up, so find out a little bit about the history and the physical exam, stick them and get that troponin drawn, and then finally, take a look at them and find out how hot they are. So here is the spectrum of acute coronary syndromes. You can see presentation, they come in, and then you do the ECG, and then you can divide them up pretty quickly into the non-ST elevation, because they don't have ST elevation, or the ST elevation. And then, based on the enzymes, we can give them their final diagnosis of either unstable angina, non-STEMI in the case of the non-ST, and then STEMI, of course, in the case of the ST elevations. So what do the ECGs look like for these? So for the non-ST segment elevation acute coronary syndromes, the classic findings that we get are ST depression or T-wave inversion, or both. And you can see that oftentimes, when they're treated, they will, and the chest pain's gone away, they will resolve and go back to normal. So here is a classic non-ST elevation acute coronary syndrome. This was a 60-year-old African-American with chest pain, and I'm hoping you can see on that ECG that nice ST depression that person has with their chest pain when they presented, as well as some T-wave inversion. In contrast, ST segment elevation myocardial infarction, it is called that because us dumb cardiologists, forget things. But now we say, oh, ST elevation. So ST elevation is what they're going to have. Before they get the ST elevation, however, in the first 15 minutes, the first thing that goes up are the T waves. They get these tall, peaked T waves. Then, in about 15 to 30 minutes, the ST segments start coming up. And then in about, 30 minutes to an hour, the QRS, the R wave, starts to get smaller, and actually they can Q out in as little as 2 hours into their infarction. And then weeks later, they will hopefully get resolution of that ST segment. Sometimes they are left with a residual Q wave. And you can see here, if they have a new left bundle. Okay, so, the new guidelines do, in the old guidelines that you guys probably are aware of, we used to say STEMI or new left bundle branch equals the same as STEMI. The new guidelines have said no, because what they found was they were cathing a lot of people with left bundle branch blocks, and more than 50% of them had no coronary disease. So they've kind of fine-tuned that in the new guidelines. And so what they're saying now is if you've got a new left bundle branch block and they're hemodynamically unstable or have heart failure, that is called a STEMI equivalent. Or if they have a old left bundle branch block and they have the Scarabosa criteria, that's also called a STEMI equivalent. So when they use those criteria, much more of the people did have true STEMIs. So that's the new definition for STEMI with left bundle. And we know that depending on where the ST elevation is, that can help us determine what artery is involved. And so you can see there, for example, with leads V5, V6, 1 and AVL, that is a lateral STEMI, and that's typically with the left circumflex artery. Remember, circum around, flexo bend, so it's the artery that goes around the heart on that left side. So here are some examples. This is a 68-year-old Caucasian male with severe chest pain. And he actually came in with ST elevation all over the precordium, V1, 2, 3, 4, and the lateral 5, 6, and 1 in AVL. So he has anterolateral ST elevation. So he has both the LAD and the circumflex. And, you know, Occam's razor, he had the left main lesion, which was appropriately stented. And then does anyone know this particular change that he has here with big T waves and this big ST elevation? We sometimes call this something. Anyone got any idea? Starts with tombstoning, yes. And it's called, and that's yes, because it looks like a tombstone. And as guardians of the medical galaxy, if you guys don't recognize this, then you'll be buying their tombstone. And you know those Italian marble imported ones can be quite expensive these days. Inferior STEMI. Here's a person who came in, a 56-year-old Hispanic male, chest pain radiating to the neck. And, you know, this was about 4 hours ago it started, and you can see he's already queued out, and his STs have started to come down. But this is an inferior STEMI, just a little bit later on. Okay, question. A 70-year-old Caucasian male presents with substernal chest pain. He takes lisinopril for hypertension and 50 pack-year history. Here is his ECG. So this is someone coming in with an ACS presentation, and based on his ECG, what do you think he has? So take a look at his ECG. Do you think he has, and it's in your book too, an anterolateral STEMI, AFib, a non-ST segment elevation ACS, or non-cardiac chest pain? Which one do you think he has? And the clickers, I have a 100% feeling going on here. Oh, okay, well, close. So this guy, he had ST depression on his ECG. So you, and I can, hopefully I can show that to you. You can see that ST depression here, V3, V4, V5, V6. He's also got ST depression there in 1, 2, AVL. So he's got ST depression. He does not have ST elevation. So that clears off A. So he doesn't have a STEMI. He doesn't have AFib. He's in normal sinus rhythm. And, you know, non-cardiac chest pain, unlikely. I mean, he has chest pain and ECG changes. You have to assume that he's got coronary disease until proven otherwise. So we can't call him D at this point. Let's now talk about markers for acute coronary syndrome. So what markers do we use? You can see here, you raise your glass to troponin I and T because they are awesome. They are very, very sensitive and very, very, not so very, very specific. But troponin I's in particular are from the heart. Whereas the older markers that we use, the CKMB, I mean, we had them in the brain, the liver, and all of that. So this is a very good test. It is now considered the gold standard in all of the guidelines. As mentioned, it's sensitive, but not specific. And I'm sure you all have seen troponitis in your hospitals. And, you know, we know that even stretching, you know, just stress on the heart, someone in really bad heart failure or someone who is septic, you know, where the heart is pumping a lot, that can even release a little bit of troponin. They can have positive troponins. But the classic raising up and peaking that you see is pretty good for acute coronary syndromes. So it's the rule of fours with troponins. They elevate at 4 hours, they peak at 24 hours to 44 hours, and then they go down by about 14 days. And troponin I, remember, is actually, you know, anatomically, it's part of the ternary complex of troponin, which is the sort of the ambassador between the actin and the myosin. Remember, the troponin T, I, and C are there. So that's what we're physically measuring. Now let's talk about How do we manage acute coronary syndromes? Let's talk about the non-STs first. So with a non-ST elevation ACS, we get them in, get them the aspirin, the P2Y12 ADP platelet receptor inhibitor. Remember, that's going to stop platelets from joining together. We give them oxygen if needed. We beta block them. We hit them with a high intensity statin, and then nitrate as needed particularly if they're having chest pain or really a lot of dyspnea. But do remember, nitrates are contraindicated if they've been using any of the PDE5 inhibitors. So ask your males if they've recently taken those. If they have severe aortic stenosis, hypertrophic cardiomyopathy, a right ventricular infarction, or their blood pressure is under 90 or 30 millimeters below baseline, you should not be giving them the nitrates. And then we want to give everyone an IV anticoagulant, and then telemetry, and as I said before, the hotness level. And I'm not talking about, are they like Jessica, Taylor, or the Hammersmith brothers, or Adam, in terms of hotness. I'm talking about Timmy, America. Age greater than or equal to 65. Markers elevated. ECG ST deviation. Risk factors greater than or equal to 3. Ischemia, 2 or more anginal episodes within the past 24 hours. CAD, that is a known stenosis greater than or equal to 50%, or aspirin use in the prior 7 days. And why is America awesome? Because, we're all chilling out here. But it is also awesome because you need to do this in the boards so you know what to do next. Because we know that the TIMI risk score, what their risk score is when they come in, that will determine what you all do next. So if they have a low score, 0 to 2, which is considered low, generally we will do a ischemia guided strategy. So we may do a risk stratification test like a nuclear stress test or some other test, might do an echo, etc. Because we know that their chances of having badness happening are pretty low. However, if they have an intermediate score or a high risk score, so anyone basically with a TIMI of 3 or more, we know that they have a quite significant risk of something happening bad if we don't kind of take a look and intervene. In other words, something happening, a major cardiovascular event within the next couple of weeks, 20, 40%, those are quite high. So generally we will send them for early cardiac catheterization. In addition, these are also considered high-risk patients. Some places use the GRACE score if the GRACE is over 140. If they're having recurrent refractory angina, with either ECG changes going up or down, or troponins continuing to rise, or they're either hemodynamically or electrical instability, or they have a high-risk stress test, or you do the echo and the EF is under 40, or they're presenting with heart failure, or they've had a recent PCR cabbage within the last 6 months, those generally fall into a high-risk group, and we should go early coronary angiography with those individuals. Also, remember your antiplatelet therapy for these individuals. You should be doing aspirin. You should be doing the P2Y12 receptor inhibitor. And that should be continued. If they're coming in with an ACS, they are on dual antiplatelet therapy for at least 1 year. Now, be aware, because you are using ticagrelor or Brilinta, there is a reasonable percent, 15% of these individuals can get what's called ticagrelor-related dyspnea. So they actually start getting dyspneic, and you do an echo, EF's fine, they don't have diastolic dysfunction. Some even get a BNP, normal. And this is a direct effect of this medication on them. So if you have this situation arising, normally what we do is we will switch them to clopidogrel because it is not associated with this dyspnea. But it is something that you will see, as you can see in about 1 in 6 people. Of course, in addition to the aspirin and the platelet blocker, we are also going to give them anticoagulants, typically unfractionated heparin or enoxaparin. We can use, some places use other agents in special cases. What about someone who is coming in, they're so hot, they're on fire, literally. They're still having the chest pain, they're really bad, and we're like, okay, I'm pushing this person to the cath lab myself right now. We want to get them cathed right now. Well, the clopidogrel or the other ADP receptor agents, most of them, they have to swallow them, they have to be absorbed through the stomach, go to the liver, and then be converted. So it takes time, it takes hours. If you don't have that time, normally what we will do is we will give them a GP2B3A inhibitor, which is given intravenously, and it immediately, instantaneously blocks those platelet receptors so that they're taken out of the equation. And we've got a couple of different options to use for them. And just remember to be checking lab work on these individuals each day, because if you get a significant drop in platelets, or you may need to change therapy. If they're going early invasive anticoagulant, of course, the bottom line is here, guys and girls, we are putting this thing up inside their artery and inside their vessels. This is a foreign body, and things like to stick to it. So when we're doing the catheterization procedure and the stenting, we have to have them super anticoagulated. So we actually often have them on very high doses of these anticoagulants during the actual procedure. How about those cocaine and methamphetamine users? We like to, these are the Friday night or the Saturday night specials in our emergency room. I'm talking, gurneys in the hallways, IVs being yanked out, restraints because, otherwise they'll punch the nurse, speaking in languages that have not been described by the World Language Society as yet, and spitting at doctors, etc. Some of these people are crazy, okay? Real crazy. And what is going to happen to your heart rate and your blood pressure when you're crazy? Okay, it's going up. So that means they're going to get more ischemia and they're going to kill more muscle cells. So what you want to do if someone is acutely intoxicated, number one, hold on the beta blocker. There is some evidence that unopposed alpha will worsen their afterload. And secondly, relax them, get them relaxed. So, whatever dose of, Ativan or Valium that Aunt Millie takes, multiply that by about 40 and give it to them, because remember, their livers are like, and get them relaxed, okay? The nurses will love you. They will be nice and peaceful in sleep, and the heart rate and blood pressure will go down. In fact, studies have shown on these cocaine people where they've actually compared just aspirin and Ativan and nitrate, compared that to full ACS protocol, that they actually did the same. In fact, one study they did better. And it makes sense, because if they're calm, their heart is not working as much, they're not getting as much ischemia and infarction. Okay, question 8. Now, a hint here, guys and girls, do your TIMI risk score. So remember, America, very important. A 41-year-old African-American female presents with chest pain for the last month, but since last night, she's had it at rest. 3 episodes, each lasting about an hour, woke up from sleep, severe 9 out of 10 chest squeezing. So she's got lots of risk factors you can see there, and dad had bypass surgery at 40. She's on aspirin, lisinopril, hydrochlorothiazide, rosuvastatin. Vital signs are okay, and the physical is good. You get a troponin back, 1.1, abnormal, high troponin. The ECG shows 1 millimeter ST depression in V4 through V6. So you start her home meds, and you've got her on, your blood pressure's controlled, heart rate's controlled, but despite that, she says she's having this 6 out of 10 chest pressure at rest, and she's now diaphoretic and nauseous. So hopefully you've done your TIMI risk score, and the question is, what do you want to do now? Do you want to thrombolize her, stress echo, urgent coronary angiography, or regiotensin nuclear stress testing? And your TIMI score should give you the answer. I got a 100% feeling here. Do you all have a 100% feeling as well? Okay. Yay! Give yourself a round of applause. Second lecture. I think that's a record, isn't it, Rex? Yes? Okay, good. Okay. So, by the way, what was her TIMI risk score? What did you guys get? Yeah, it was way up there, right? So she needed to go to the cath lab. Very good. Now let's talk about treatment of STEMI. And, I'm going to tell you, you can't take a pill and a Ibiza and be better with STEMI. We got to remember, this is complete occlusion, as you can see there. So STEMI, our checklist when they first hit with a STEMI, pretty similar, except beta blockers are really, really beneficial in STEMI, especially beneficial. They're in non-STEMI as well, but make sure to get them the beta blocker, because they are going to reduce ventricular arrhythmias and improve survival. Also, In those individuals that come in, especially if they come in with heart failure or an EF less than or equal to 0.4, we want to get them on an ACE, ARB, or an aldosterone or an aldosterone antagonist early on. Now, the main key difference is with STEMI is that most cases we're not messing around with scores or doing anything. I mean, they have a complete occlusion. Muscle is dying. We need to reopen, reestablish flow ASAP. And this is what I'm talking about here. Here's someone with a right coronary artery presented with right coronary artery STEMI with ST elevation 2-3 AVF, complete occlusion, and then reopened successfully. This is what we need to do in most of these cases. And we know that this works. Not only does it work, but it's better. In the old days, we used to do a lot of this thrombolysis, but all of the studies pretty much showed stenting is better than thrombolysis if you can get it early. So our goal is to do it within 90 minutes of first medical contact if they come to a PCI hospital, or they give you an extra 30 minutes if they're taken to a hospital that doesn't have PCI and they have to be transported. So 120 minutes. And essentially what we're doing is we're finding that occlusion, we're kind of bumping the clot out or sucking the clot out and then inflating a balloon with a stent and reestablishing very nice flow. You can see here after the stent. Now, the older, obviously, is older someone is, the more complications and the less effective it is. However, we've found that we're getting better and better, and the stents are getting better and better as well. Now, radial access is we are doing more and more through the left radial artery. It's pretty much a direct shot up there, and we're doing more and more stenting through this route. The advantage is you don't have to wait if someone's on Coumadin for their INR to go down as much, so you can do it at an INR 2.2, advantage number one. And advantage number two, it's very easy to control if they have any hematoma or compared to in the groin. So we like to do it if we can through the radial approach. Now, bare metal stents, we can do bare metal stents in those individuals who we think are kind of high risk, especially for dual antiplatelet therapy. So someone, for example, who is a really high bleeding risk, or you don't think they're going to be able to comply with 1 year of dual antiplatelet therapy. Or they're having a planned procedure. So this would be the classic case that I see with this is someone who has cancer and they're wanting to go for a resection and they are having chest pain, and we stent them, and then with the newer stents, they're getting a little bit better with the drug-eluting stents, but the guidelines have not caught up with that. So right now, just so you know, in terms of the duration, because the boards like to ask about duration of dual antiplatelet therapy for you guys. If someone comes in with an acute coronary syndrome, regardless of what happens, so if they present with chest pain, they come in with an acute coronary syndrome, regardless if they get cath stented or not, that person should be on dual antiplatelet therapy for a year, 365 days, regardless of what happens, okay? If someone comes in with, you're seeing them in clinic and they're having, stable angina, which has gotten worse, so it's not a acute coronary syndrome presentation, but it's just, their angina is progressing, then you have the bare metal stent 1 month rule, and the drug-eluting stent is still 365 day rule. Now, as I mentioned, the drug-eluting stents are getting better now, and they're more sophisticated. So now, and the new guidelines have not completely come out as class 1, but you will see that in the future. It'll be probably dual antiplatelet for 6 months with the newer drug-eluting stents. But right now, that's what you need to know. And for STEMI, the antiplatelet and anticoagulant is essentially the same as someone who is coming in with a non-STEMI. Now, fibrinolytic therapy. Let's say that you have a person that comes in, and it might be that you're out in the middle of nowhere and you don't have any PCI available, or it could be that you're at a place, but there's a really bad snowstorm, so helicopters or ambulances, they can't be transported to a PCI hospital. So if you have someone where primary PCI is not available in a timely manner, 90 minutes, or 120 minutes if it's non-PCI hospital, or if they present within 12 hours of their symptoms, the recommendation per the guidelines is to give them fibrinolysis. So the fibrinolytics that we have right now are fibrin-specific, tenecteplase, retiplase, alteplase, which are better. They open up the blood flow better. So TIMI 2-3 is better flow. TIMI 0 flow is no flow. And then you've got the non-fibrin specific, which is the streptokinase. And essentially what we're doing is our goal is to dissolve this clot, but hopefully you can see that the actual plaque is still there. So, it's good to get this dissolved, but we often have to deal with this plaque here later. So firstly, what are the acute absolute contraindications to giving fibrinolysis? So any prior intracranial hemorrhage, known structural cerebrovascular lesion, known malignant intracranial neoplasm, ischemic stroke within 3 months, except, of course, an ischemic stroke that you're seeing under 4.5 hours, because now we are actually treating that with IV RTPA. Okay? Suspected aortic dissection, active bleeding or bleeding diathesis, significant closed head or facial trauma within 3 months, or spinal or intraspinal intracranial surgery within 2 months. If their blood pressure is severely high, because we don't want to give them thrombolytics if their blood pressure is real high, because it increases the chance that they'll have an intracranial hemorrhage. And then for streptokinase, if they've received it within the last 6 months, because they can have this allergic reaction, which is really nasty. Okay, let's see if you have got that information. So a 51-year-old woman is seen in the emergency department for chest pressure and nausea that started 90 minutes ago. She's got cardiovascular risk factors. She's on pravastatin and hydrochlorothiazide. So blood pressure and heart rate is stable. On oxygen is 97% on room air. Her troponin is very positive, and there's her ECG. So take a look at her ECG there. So you start aspirin, clopidogrel, and IV heparin. The nearest PCI hospital is 3 hours away. And she's already had chest pain for 90 minutes. So the question is, what is the most appropriate treatment? Admit to ICU and observe, full dose retiplase, and then transfer to PCI capable hospital, transfer for primary PCI, or half dose retiplase with eptifibatide, and then transfer to PCI capable hospital. So there are your possible choices. Let's see how the Guardians of the Medical Galaxy are doing on this one. Wow, you guys are totally rocking it. Dr. Starlord is proud of all of you. So full dose retiplase, right, and then transfer to PCI capable hospital. So most of you guys got that. They've done the studies for the people that chose the half dose retiplase with eptifibatide and then transfer. They actually had higher morbidity and mortality with doing the combination. They were bleeding, they had all sorts of problems. That's been abandoned now. You either fibrinolyze them, then send them to a PCI hospital, because remember, if the clot comes back or the plaque gets more unstable, we need to act. Most of them are going to get cathed anyway when they get to the PCI hospital in a few days. And no one picked the other ones. But just remember, those kind of funky combo things we are no longer doing, and they're not indicated. Good job. Let's now talk about STEMI and cabbage and antiplatelet treatment, because this comes up a little bit. So let's say someone comes in with a STEMI, and you do the usual things. In the old days, some people used to say, oh, don't give them any antiplatelets, because most likely they're going to go for cabbage. No, we don't do that generally anymore. We do the usual stuff, and honestly, the way it happens in the real world is if you can hold those agents, and that would be more kind of, I think, in more of a sort of a semi-elective situation, we hold them if you can, because we know that those increase, the bleeding during the surgery. But in the real world, honestly, what happens is if they need to go to cabbage urgently, they go. It just means that our anesthesia buddies have to give them a little bit more platelets and products or blood during the actual procedure. Now, what about beta blockers? I told you before, beta blockers are really, really beneficial, especially in STEMI, but also in the non-ST ACS. However, if you have someone who presents in heart failure, or they've got low output state, or they're at very high risk for cardiogenic shock, that tends to be more the elderly people, those with lower blood pressures. Those with a prolonged first-degree heart block, first degree or a second or a third degree, but they don't have any pacemaker in place, or they have active airways disease, asthma, or really, wheezy COPD, then you may want to consider diltiazem if you want to slow the heart rate down. Now, one of the things that happens with STEMI in particular is that the mineralocorticoid receptors are activated. And, you might say, well, so what? Well, the so what is when they get activated, some of the stuff that they do is not good at all. Vasoconstriction of the blood vessels. You can see here muscle hypertrophy and fibrosis in the heart, not good. I mean, that's stuff we don't want. We want the heart to have good blood flow and repair. So oftentimes with STEMIs, we will want to block this whole system, and we do that with these renin-angiotensin-aldosterone system inhibitors. The ACE inhibitors in particular are beneficial, started within the first 24 hours. Someone with an anterior STEMI who presents with anterior STEMI or heart failure, or you do an echo and they have an EF less than 0.4. Get them on the ACE or an ARB if they can't tolerate the ACE. And then your aldosterone antagonist, so if they're already on ACE and beta blocker and they had an EF less than or equal to 0.4 with heart failure or diabetes, that is a particularly high-risk group. We generally will also add on an eplerenone is the one that was studied the best in the EPHESIS study. Be aware, however, that they don't have any contraindications. So just make sure you check the creatinine and potassium and make sure they're not taking another medicines that will interact with that aldosterone antagonist. Okay, right ventricular infarction. Right on share. So think of a right ventricular STEMI if you've got share, clear lung fields, hypotension, and elevated JVP or Kussmaul sign. Think of RV infarction. And RV infarctions, 50% of them will have an inferior STEMI as well. So you've got to be aware of that. And to check that out, what we ask for, if you see someone with an inferior infarction, we ask for right-sided leads. And we're looking for ST elevation of 1 millimeter or more in V4R, lead V4R. Why is it important to know if they have right ventricular infarction? Why don't we just treat them the same? The reason is, if the right ventricle is not pumping blood properly to the left heart, all sorts of badness can happen. And they can even crash and burn if you give them certain medicines, including things that we often routinely give these people, like nitrates, like morphine. They will crash and burn. So if they have a right ventricular infarction, no morphine, no nitrate, and oftentimes start them on wide open normal saline, because they're going to need as much kind of passive pushing of fluid from the right side of the heart to get to the left side of the heart. And if they are still hypertense, then consider adding dobutamine as well. Question 10. Regarding acute STEMI treatment, which of the following is true? Often includes early reperfusion with primary percutaneous coronary intervention, includes a parenteral IV anticoagulant, such as unfractionated heparin or enoxaparin, P2Y12 receptor inhibitors, including the thienopyridines like clopidogrel, prasugrel, or the non-thienopyridines, ticagrelor, are mandatory, may include early reperfusion with fibrinolytic therapy, if not contraindicated, and if PCI is not immediately available, or all of the above are true. So I have another 100% feeling going on with the Guardians of the Medical Galaxy. Let's see if my crystal ball is working today. Wow, awesome. Okay, so 99% I will take that. So yes, all of the above are true. Now, the person that choose D, yes, absolutely, we will do fibrinolytic therapy if PCI is not immediately available, particularly if we can't get it within 120 minutes. But these other things are also true. PCI is often the way to go. IV anticoagulant, yes, is required. And the P2Y12 receptor inhibitors, yes, are mandatory. Okay, let's talk about complications of acute coronary syndromes. Here is a classical mechanical complication, a rupture of the interventricular septum. And Pitbull and Christina would not be happy if this happened to them while they're on stage. So mechanical complications, let's talk about those. Typically, so the person comes in with their acute coronary syndrome, and they're treated and all of that, and they have a big one often, and then 2 days later or 2, 3, 4 days later, it's always just at the point where, they're being transferred out of the CCU, and you know the deal. Family's there, and you're saying, how is he doing today, doctor? Oh, wonderful. He's doing so well today. We're going to transfer him out to the floor. And they're like, oh. And then, later in the day, it's like code blue, 2A, and it's your patient, of course. And they're in extremis. They're coding because they're having one of these events. So moral of the story, they are stable right now, and we are cautiously following them, okay? The moment you promise them something, the karma might happen. Anyway, so the main ones that we will see, the mechanical complications that we see, are left ventricular free wall rupture, a papillary muscle rupture, in particular with the right coronary artery, because we know a right coronary artery STEMI, one blood flow from the right coronary artery, one supply supplies that posterior medial papillary muscle. And when that's taken out, that can get ischemic, die, and it can pull off. So in particular, think of that if someone's come in with an inferior STEMI. Rupture of the interventricular septum, and then finally, just severe cardiogenic shock, like our patient who in lecture 1 who presented with a cardiogenic shock. So what do you want to do? I mean, obviously what's going to happen is, it's going to be a code situation. So in one hand, or get your tech, grab the echo and find out what's going on, because the echo oftentimes will tell you what the cause is. And then in the other hand, speed dial the cath lab or CT surgery, because oftentimes these people are going to need to go urgently to surgery, especially the left ventricular free wall rupture and the mitral regurg with the papillary muscle rupture and the rupture of the interventricular septum. They need to be fixed, in the OR. If you can get someone who's going down the cardiogenic shock pathway, if you can get them in the cath lab really early on, get that fixed, they often will do better. But you can see, particularly with the left ventricular free wall rupture and the cardiogenic shock, the mortality is very, very high with them. Also, we can see electrical complications of myocardial infarctions. This is one of the ones that we fear the most, but we do see ventricular fibrillation. You can see on that ECG. You want to, get them. They're going to be coding, cardiovert them, and if they have unstable ventricular tachycardia, you want to cardiovert them. And most of the time, you are going to get them to the cath lab. Most of the time, this means that something's happened. They've got ischemia back, and the ischemia is causing the ventricular tachycardia or the ventricular fibrillation. If they're more stable, their blood pressure and everything is stable, you can try treating it with IV amiodarone, et cetera, and doing further workup. What about the implantable cardioverter defibrillators? So with these, I think, the main thing for you guys to know, if you've got someone with heart failure, regardless of whatever the etiology is, if they have heart failure, NYHA 2 to 3 with an ejection fraction less than or equal to 35, you should at some point refer them for evaluation for a possible ICD. What about the person, who's come in with an acute coronary syndrome? Let's say you had a big STEMI person and, they went to the cath lab, they got stented, all fixed, no more chest pain, but yet they're still having VT and VFib for, a couple of days later. And you've checked all the reversible causes. They don't have, electrolyte abnormalities. They don't have anemia. They're well perfused. Then what mostly probably happened was that their event caused a damage in such a way that it set up a focus of VT in the muscle of the heart. And those individuals actually need to get an ICD before they go home. If they can't get an ICD for some reason, then we do have another option, and that is the life vest. Especially the guidelines mention, especially if they have an infection, developed, like maybe they got a urinary infection or some other infection that you're treating that you don't want to put an ICD in now because it'll get infected, then think about the life vest. So the ICDs in general, while we're on ICDs, we can use them either for primary prevention. So that means they've never had a cardiac arrest and they haven't collapsed yet. And as I mentioned to you before, regardless of the etiology, ischemic or non-ischemic, if the EF is less than or equal to 35% with NYHA 2 to 3, those generally should be referred to EP. And sometimes they'll do some further evaluation, especially if it's one of those cases where it's, maybe non-sustained or sustained VT. Now, for secondary prevention, in other words, that's someone who actually has had a cardiac arrest or symptomatic VT or syncope from VT. So in those cases, honestly, most of them are going to get a device. But if there's a specific and clear reversible cause at the moment that they had the VT, like their potassium was 2 and they had VT and now it's fixed, then you can consider not doing it. But all other cases, most of the time they're going to end up with a device. And we do have 2 zones and 2 therapies for ICDs. The first zone is what most people prefer. It's what's called ATP or anti-tachycardic pacing. And what happens there is if the person's in VT, the device looks at the rate. So, for example, a typical rate might be 180. And the device actually starts pacing at a faster rate, like say 185 or 190. And the pacemaker pacing kind of catches on with the rest of the heart, and the VT just dies out. And it's pretty successful in a lot of people. However, if that doesn't work after a couple of times, or the person is in VFib, it will then deliver a shock. And the typical joules are 35 internally. Okay, now let's talk about stable ischemic heart disease. And they're not perfect. This is perfect. They're not perfect, but we can try to make them a little bit more perfect, especially with their symptoms. And we do that by treating them with various medications, nitrates, beta blockers, dihydropyridine calcium channel blockers. Remember, they block the L-type calcium channel of smooth muscle, but they are associated with peripheral edema as well. So you're talking nifed, amlodipine, and felodipine here. And all of these agents work essentially by decreasing the work the heart has to do, by either slowing it down and or reducing the blood pressure it has to pump against. And they're pretty effective. Now, ranolazine or Ranexa is the new kid on the block. So this is indicated now, per the guidelines, if you have persistent angina on maximal medical therapy or a beta blocker substitute. So that if for some reason the person cannot take beta blocker, the common ones I see are, asthma or bad COPD, then Ranexa or ranolazine is indicated. And the amazing thing about this is it doesn't affect the heart rate. It doesn't affect the blood pressure. It actually has a direct effect on the energy system inside the cell, like at the mitochondrial level, and it actually relaxes the heart muscle and reduces stiffness without those effects on heart rate and blood pressure. So it's pretty cool. Just be aware, especially if they're on DILT or verapamil, that to reduce the dose of the Ranexa, because these are what are considered moderate CYP3A inhibitors, and they do interact. And so here are the ones you need to know, and my little mnemonic here is the strong NP kicks Randy. So strong CYP3A inhibitors, these are the ones where you do not want to use Ranexa. So nifazodone, if they're on any of the protease inhibitors, so pretty much your patients with HIV, if they're on active heart therapy, you don't want to use it. Ketoconazole, itraconazole, clarithromycin, those medicines are contraindicated with ranolazine. So just check that list before you start someone on ranolazine. Of course, the diet, we do the usual things, diet. We want to cut down the fat and the cholesterol. 10 is the new 5 for fruits and vegetables, guys and girls. So you should be eating 10 fruits or vegetables a day. Mediterranean diet, by the way, has been ranked as the top diet for cardiovascular disease patients, so think about that. Statin everyone, and blood pressure. We want to get the blood pressure really, really well controlled. And in most cases, you want to get it that is under 130 over 80. Exercise, we know that's important. It builds collaterals. It improves production of nitric oxide, improves symptoms, improves psychological symptoms, well-being, etc. And just watch the waste. Smoking, of course, this is a no-brainer, but you want to check on people. Ask, advise, assist, arrange, avoid, etc. And this also now, a new thing just came out just recently, vaping as well is also considered. So don't get your persons off the cigarettes and say, oh yeah, the vaping's okay. Actually, no, it's now considered a cardiovascular risk as well. Antiplatelets, aspirin, most of them should be on aspirin, those with stable ischemic heart disease. If they can't take aspirin, then go with clopidogrel. Beta blockers, we want them on beta blockers. If someone had a sort of a small non-STEMI and maybe it was one of those ones, they were anemic or, there was another kind of reason and it was a type 2, what we call a type 2 infarction. That is, and they have good EF, you can actually, after 3 years on the beta blockers, you can actually stop the beta blockers. And a lot of people find that beta blockers just really slow them down, and the men do not like them as well because they definitely causes erectile dysfunction. In contrast, if they do have LV systolic dysfunction, that is EF less than 40%, those all should be on your guideline-directed beta blockers, which is carvedilol, which is probably the best because it has both alpha and beta effect. Metoprolol succinate, remember the S for the sustained release. A common brand name is Toprol XL for this. You want the sustained, okay? Just remember that. I see a lot of patients in my heart failure clinic that are on the tartrate, and that's not evidence-based for heart failure reduced EF. And then finally, bisoprolol, that's the other medicine that is indicated. ACE inhibitor, of course, as we talked about before, especially if they have low ejection fraction, diabetes, hypertension, or chronic kidney disease. If you've got someone who, despite your best medical therapy, is still having symptoms that are limiting their ability to do ADLs, and you've got them maxed out, then that's the time when you want to send them to the cath lab. And if they happen to be on a NOAC, typically just held those 1 day before the cath. Influenza and pneumonia are very important for them as well. There's another thing that we have called microvascular angina. It goes by various names, cardiac syndrome X, all of these things. So this is when we have a person comes in, they have a good story, we do a stress test, the stress test may even be abnormal, and then we do the cath, and the cath comes back normal. The epicardial, the LAD, left circumflex, right coronary, all normal. And it's like, what? What is it? And you may have been treating them, and they may have been responding, for example, to Imdur, and other anti-anginal therapy. This is a very common syndrome, particularly in women, and it's likely the small perforating vessels, so the branches off the epicardials that are going in, like the septal perforators and those, have some sort of endothelial dysfunction, and they're not working well. And we like to, interestingly, the same treatment will work for those individuals. Okay, let's have a question. Your coronary artery disease patient has persistent exertional angina despite being on a good medical regimen, which includes maximal doses of isosorbate mononitrate, metoprolol succinate, lisinopril aspirin, and atorvastatin. So you're on a good medical regimen. Providing there are no contraindications, what medicine could you add to the current medication to improve their angina? So there are your choices there: amio, candesartan, vitamin E, niacin, or ranolazine. What medicine, and I'm having that 100% feeling again, might you add that will help their angina? They're already on everything that we normally do. Excellent. Okay, we got 99%. I'll take that. So vitamin E, just so you know, actually has been one of the ones that the meta-analyses and the group out of Oxford and others have shown that are no longer beneficial. Just like most omega-3s that you get over the counter. I have a lot of people that are taking vitamin E and fish oils. Most of them do not work. They're not evidence-based, so you can save them some money. PCI, let's talk about percutaneous coronary intervention. So if they're still having symptoms despite the maximal medical therapy, or you do a stress test and they have high-risk findings, that's when you should send them for PCI. Importantly, it'll improve their symptoms, but does not improve their survival. And they will most likely have to come back for another PCI, more so than if they'd had CABG. I've already talked to you before about how long to delay surgery if they've got a stent. So if it was for kind of chronic stable angina, 30 days for bare metal, 6 months to a year for drug-eluting, and if they came in with an ACS, 1 year dual antiplatelet for both. And if you are going for surgery, we generally like to hold the clopidogrel or whichever, prasugrel or whatever they're on, 5 days prior and continue the aspirin. CABG surgery. Well, CABG is good, and importantly, it will improve symptoms and survival for a certain subgroup of patients. And who are those patients? Left main disease greater than or equal to 50% stenosis, or 2-vessel disease with proximal LAD being involved and diabetes or low EF. They actually get survival benefit. So you should make sure to send those individuals to your surgeons. But On the flip side, if they don't fall into that category and they have single or two vessel disease these days in 2019, you can actually treat them either medically or send them for a stent or surgery. So we have a lot more options, and we're doing more and better medical therapy these days. Okay, let's talk about hyperlipidemia. Now I put this up a little bit tongue-in-cheek. This is a burger joint in Austin. And this particular burger, I think, is called the Heart Attack. Its buns are Krispy Kreme donuts. It uses 50% fat Wagyu beef, only egg yolk as the egg, and it has 2 slices of lettuce on it. And this is the Heart Attack. And actually, I do put that up a little bit of tongue-in-cheek because we know that actually 70% of your risk is genetic for cholesterol. Very little is affected by diet. I mean, you can do a little bit, but not much by diet. Also, I want to remind you that the guidelines do talk, and this is a radical change for these guidelines, do talk about 2 groups of people that have not been shown to get benefit from statins. That is non-ischemic cardiomyopathy and people who are on hemodialysis. So for those individuals in general, I would not use statins for them. But these individuals are these are the final 4 groups that are indicated for statins. So if group number 1, and I've got this little mnemonic to try to help you remember, in Cal, the high doctor was modern. So high, it's all about intensity of statin these days. So who should receive high intensity? That's basically the max dose statin. The individuals that should receive the high intensity are the Cal group. So C for cholesterol treatment, A for atherosclerotic disease. So anyone who has any atherosclerosis anywhere in the body should receive high intensity statin. We're talking a Torva 80, 40 to 80, Reserva 20 here. Or the L is if they have an LDL cholesterol greater than or equal to 190. Typically that means they have a familial hyperlipidemia. And as I said before, most of their lipids is genetics. Those are the highest risk. Primary prevention has been shown to be beneficial for those group with the LDL greater than or equal to 190. So those should receive high intensity. Now, what about the doctor was modern? So those who have diabetic, who are 40 to 75 years of old, or those who have a risk of 7.5 to 20% atherosclerotic risk at 10 years, they should receive the moderate intensity statin. And those are typical doses like Simva 20 to 40, Atorva 10, Reserva 10, Prava 40. So that's basically it. With the new cholesterol guidelines, in the old days, it used to be all about, let's check what their LDL is, we've got to get it down and all of that. It's not about that anymore. It's about intensity. And in fact, if you read the guidelines all the way through, which I've done several times, they mention several places that, in fact, regardless of the indication, your goal should be to get those persons to the highest intensity statin possible. In both primary and secondary prevention, that has shown to reduce the events and reduce plaque buildup and improve endothelial function. So it's about the intensity of the statin. Now, if you have someone who is a diabetic, 40 to 70, and let's say they have a high risk as well, let's say their ASCVD risk is 20, then actually they move up to the high intensity statin group as well. Okay, so let's do a question. 49-year-old Caucasian female comes in because she has heard there are some new cholesterol guidelines. I mean, she's got it together. She's got all of the things together. She works for Vogue magazine. She struts in her Louboutins. She's got her Prada skirt and her Guess blouse on and her Hermes bag. And she holds up her phone and it's like, doctor, new guidelines. So she's got type 2 diabetes and has taking metformin. Blood pressure's okay. Total cholesterol 179, HDL 55. Her 10-year ASCVD risk is 1.9%. So the question is, what should you recommend for her based on the new guidelines? Fibrate, ezetimibe, niacin, or moderate intensity statin? Let's see how the 100%ers are doing. All right. So, yes, most of you got it. So she falls into diabetic at the right age group. So she is indicated for moderate intensity statin. Niacin, unfortunately, hate to break it to you guys, but niacin does not work. does not work in most individuals. So the guidelines actually specifically stated, forget about most of these other drugs. Also fibrates, they said, forget those. They are worthless in most individuals and have lots of side effects too. Ezetimibe, no, ezetimibe is not considered a first-line therapy. It is considered a potential second-line therapy if someone is statin intolerant. So moderate intensity statin is the way to go here because of our diabetes. So in this lecture, we're going to be talking about peripheral arterial disease as well as some other embolic disease and the valvular diseases. So peripheral arterial disease, the mantra here, guys and girls, is PAD, die from CAD. Repeat and augment. PAD, die from CAD. Okay, you guys need to get your coffees going or something. It's more common in men, and as I said, when you see PAD, you should think CAD in these individuals. So we do the screening for PAD with the ankle brachial index. We have them lay down, and we take a ratio of the highest systolic blood pressure in the ankle, and we divide it by the higher blood pressure in the brachial artery. So again, remember you've got this big tube coming out of the heart called the aorta, and it's going big flow down to the arteries in the legs. Normally when you're laying down, the pressure in the arteries and legs should be the same, if not larger, than the brachial. And the reason that is because remember the arteries that go to the arms come off early from the aortic arch. They're a lot smaller, and so the pressure is attenuated. So normally, the ankle over the brachial should be 1 to 1.4. As you get more peripheral arterial disease, there is more attenuation of flow and more resistance to flow, and so the pressure drops in the lower extremity. So now your ankle, and you may get to a situation where your ankle pressure, that is the ankle over brachial index, is actually less than 1. If it goes under 0.9, we call that significant, and that is a failure, and they have screened positive for possible peripheral arterial disease. So who should you do it on? Well, definitely if someone comes in and gives you a history of claudication, do it. But the bad news is only 1 in 5, 20% of people who actually will have claudication with PAD. So most people with PAD are walking around, they don't even know they have it. So we target those high-risk groups. So people that have lower extremity pulses that are diminished, those who have non-healing wounds, gangrene, other things, or lots of cardiovascular risk factors, or atherosclerosis elsewhere. They might have had a stent. You should definitely consider doing a peripheral arterial disease screening. Now, the big differential diagnosis for these individuals is a condition called lumbar spinal stenosis. And so they'll come in and they'll do they'll do a Rodin. They'll lean over, or these are the ones that, in hospital beds, they're always leaning forward like that, because that gives them instant relief of when they flex their spine, it opens up and the nerves are not being pinched. Whereas when they extend their spine by walking or going down a hill, they actually get worse symptoms. Importantly, they often give you a story. They'll tell you, doctor, it's very interesting. Whenever I go shopping, at H-E-B, Kroger, or Walmart, I don't mind at all. I don't get my symptoms because they are bending over the shopping cart. So anyone who tells you that they actually like going shopping at H-E-B, Kroger, Walmart, etc., light bulb should go off. Something's going on here. Okay? While we like it to be like the textbook, it should be bilateral, oftentimes they will tell you it's worse on one side. You can check deep tendon reflexes, etc. And we want to make sure we diagnose this, and the diagnostic test which will give you the answer is the MRI of the lumbar spine. And I particularly liked this La Pensure, the Thinker by Rodin. Supposedly this was Dante, outside the gates of hell, considering, to enter or not to enter? But more importantly, I love this because Auguste Rodin also gave us this quote: walking is man's best medicine. So this is fantastic. you all should, who's doing activity trackers? Who's on that? Good to see. I've only got 8,500 right now. I need to get up to my 15, but it is important to get your steps in, get active, so you don't have to deal with a lot of this stuff as you get older. Now, what if they have PAD? You do the ABI, it's like 0.7 or something like that. Then oftentimes, if you treat it medically, but if you're thinking of doing some sort of revascularization, we have to image them. And we've got different options for imaging. Here is an example of a MRI showing a nice obstruction here in the common iliac artery, which was successfully stented. So we want to treat these individuals. Remember, PAD die from CAD, so make sure you get them on aspirin or clopidogrel, just like our chronic ischemic heart disease. Statin them, get the blood pressure under control, check their feet. And if they have an infection, if there's any early sign of infection, maybe they've got something on the cuticle, or maybe it's like a little bit of cellulitis, do not watchful waiting for these individuals. You want to get them on antibiotics ASAP, because if this deteriorates, they can really, really run into problems. And smoking is the big one, and you want to do everything you can to stop them smoking. You may have to make a deal with the devil. Like, for example, you may have to tell them, if you stop smoking, I will let you bring in your cute little Shih Tzu to clinic every time, and I will give him a mani and pedi and bring in doggy treats for him. So whatever it takes, get him into a program, get him on the varenicline or whatever. And again, as I talked to you before, avoid secondhand and the vaping as well. So in terms of the treatment, one new change on the updated guidelines is they now, as first-line therapy for someone with PAD, supervised exercise, 30 to 45 minutes, 3 or more days per week for 3 months. That is a first-line indication, which means also that will be paid for by insurance and Medicare and Medicaid. So for your PAD patients, think about that, getting them into your cardiac rehab program, getting them doing that, and then getting them on, that will start them off on a strong foundation and continue their exercise when they go home from that. Silostazol is a phosphodiesterase inhibitor. This works really well. It improves their walking distance and reduces their symptoms, but importantly, they've got to have normal LV function. So the mantra here, guys and girls, silostazol, phosphodiesterase inhibitor, normal LV function. Repeat and augment. Silostazol, phosphodiesterase inhibitor, normal LV function. Okay, I wanted you to repeat that because it's really important, because if you give silostazol to someone who has heart failure of any severity, you will kill them. And the boards don't like you doing that. There are also some other options for individuals, but these are not considered class 1 right now. So if they have, just like with coronary disease, if someone is on maximum medical therapy and they're having still symptoms that are interfering with their activities of daily living, that's when we need to think about revascularizing them. It will improve their symptoms. We can do a stent, particularly for proximal or short segment lesions. Here is a right superficial femoral artery that has severe PAD and then was successfully stented here, or surgery and bypass. So this is for longer lesions and for occlusions. And I'm sure you're familiar with the classic one here is the FemPop bypass that is often done. Okay, question 13. A 73-year-old woman with a 5-month history of calf pain, left greater than right, that comes on when walking or standing, worse when walking downhill. She does not get the pain when she is pushing a cart buying groceries. She gets relief by sitting down and leaning forward. Which study will likely reveal the cause of her symptoms? An ultrasound, an aortogram, an ABI, an MRI of the lumbar spine, or CT abdomen? And here are the results. Yes, most of you guys are on the money. So this is classic lumbar spinal stenosis, which is the lookalike for peripheral arterial disease. And the best way to diagnose this, the gold standard, is the MRI of the lumbar spine. We would not do the ABI because this story is not consistent with PAD. It is consistent with the lumbar spinal stenosis. And so the ABI is not going to be helpful in this case, as are the other things. Now, acute limb ischemia. This is kind of like the STEMI of the limbs. This is complete occlusion, pain, reduction of pulses, sensory loss, muscle weakness. And this, just like a STEMI, is a medical emergency. You got to get them on IV heparin immediately, and then you have to immediately send them to the cath lab. But this time it's for invasive angiography of their arteries of the leg or their arm. And then fix it, because this is an emergency. Every time is muscle, time is myocardium, but time is also muscle here. Importantly, if they've come in early, typically that is if they've come in within 3 hours, and most people do, unless they're completely wasted and have fallen asleep outside or something like that. They may not. But typically, this will wake someone from their sleep. It's severe pain, etc. They'll come in. So most cases, that's the good news, and we can get them in, do the urgent, immediate invasive angiography, and then fix it, either with catheter-directed thrombolysis and or embolectomy or surgical revascularization. Unfortunately, about 1 in 5 person waits too long, and by the time they've come in, they have no sensation, they have no muscle strength, and they may even have gangrene, and this is immediate amputation for those. Okay, question 14. A 59-year-old man presents with acute left leg pain for 3 days, worse with exertion. Today, the pain is now severe at rest, and his foot is cool and going numb. But he's got cardiovascular risk factors. There's his meds. His vital signs are normal. His left foot is pale cool with reduced sensation and no pulses, but muscle strength is normal. Arterial, Doppler ultrasound, no pulses. IV heparin is started. So what is the most appropriate management now? Urgent left leg amputation, urgent invasive angiography, intravenous glycoprotein 2B3A, or admit and wait for watching. So he's come in. He can still move his muscles. He still can feel. Yes, urgent invasive angiography. This, remember, is equivalent to a STEMI. You need to investigate and get this open as soon as possible. So that is why B is correct. He still has strength, and he's got some sensation, so you don't need to amputate the leg. Glycoprotein 2B3A have not been indicated and studied in this field. Very good. Now let's talk about the non-atherosclerotic or arteriosclerotic vascular disease. So there are 2 common ones. One is more common in men, young men under 40. This is Berger's disease, and AKA thromboangiitis obliterans. And it's mainly in young male smokers. You can see early here, and then later you can see a complete obliteration. And this is the problem here. You can see this arteriogram. They've got a complete occlusion of those small and medium arteries distally here. You can see it's just complete cutoff here. And the main thing is here, they got to stop smoking. So just ask them, okay, here are your choices. Stop smoking, or we'll schedule your amputation. Takesi's arteritis is the commonest non-arteriosclerotic vascular disease in young under 40 women. And you can see, and the prototype here, it's particularly common in Asian women. So the prototype patient they will give you on the boards is the young Asian violin concerto player whose Shostakovich violin concerto number 1 has gone to hell in a handbasket, unlike the beautiful Shostakovich violin concerto number 1 that you are currently listening to. And so the etiology of Takesi's arteritis is its large vessel artery. So you can see here, here's your aorta, and you can see here these big vessels coming off the aorta, and hopefully you can see, do you guys see that where the arteritis is? It's almost like a string sign on those vessels. And so again, they have, very tight vessels. So whenever they're using their upper extremities, in this particular person's case, they're getting supply-demand imbalance. They're getting angina, or not angina, but actually the equivalent, cramps in the arm muscles, because the arm muscles are not getting enough flow. And we treat that with high-dose steroids or immunosuppressives. Let's now talk about vasospastic diseases. And vasospastic diseases, primary Raynaud syndrome is the commonest, again, in young women. And they will tell you this classic story of the color changes. And, it's starting to warm up. Hopefully we'll be able to get our Weber barbecues out soon. So the color changes my little mnemonic for that is Weber. So white is the first color change, and that's because they get the vasoconstriction. Then B for blue. So then finally the arteries start to open up, but the deoxygenated blood flows in. So it's more blue. And then finally they get the reactive hyperemia, and then the oxygenated blood comes in, which is red. So white, blue, red. They'll tell you oftentimes they'll have these classic kind of tri-color change. They may have some other signs. The main treatment for this is calcium channel blockers, biofeedback, or nitroglycerin. Now, I don't know about you guys, but I've tried that. Imagine next time before this happens, or as this is happening early on, imagine you are laying down in front of your beautiful, crackling warm fireplace on your sheepskin rug, and your pussycat is purring by your tummy. And warmth, you feel warmth flowing into your extremities. Well, I don't know about you guys, but I haven't had too much success with that. What I have had a lot more success with is getting them to, number one, honey-do. You go and get outside, in that cold, or you go and get the stuff out of the freezer, or having them to get a pair of those 9-volt battery-charged gloves or socks that you can get on, inside in the corners in New York City in the middle of winter. I've had a lot more success with those in reducing their Raynaud syndromes. Vasospastic angina. This is the oh my God ECG. The reason this is the oh my God vasospastic principal angina, because that's normally what happens in the emergency room. It's a young person often, oh yeah, I'm feeling a bit of chest pain. They do the 12-lead ECG, and then everyone goes, oh my God, quick, cardiology stat, and then the nurse says, okay, lay down, sir. I'm going to give you this sublingual nitroglycerin. Okay, got a bit of a headache. How do you feel now? I feel pretty good. Then they do the ECG, and it's completely normal now. And it's like, oh my God, we have an alien amongst us. Quick, get Mulder and Scully. Let's get this get this worked up, because this is not normally what happens in these patients. So the issue with, and you can see they have these huge ST, it's often all of the vessels are clamping down, and you get this widespread changes all over the place. Unfortunately, the patients that we see in our hospital, many of them do have cardiovascular risk factors and stuff, and a lot of them, you give them the nitro and it doesn't go away. I mean, some of them does, but oftentimes you have to just cath them at least once and get the diagnosis of the Prinzmetal's angina. We can also do provocative, where we can actually induce the spasm and see it, but once we've made the diagnosis, then next time they come back to the emergency room, we can just treat them and they don't have to admit them. And we, of course, use calcium channel blockers, will reduce the spasm, stop the smoking. It's often brought on by smoking, and risk factor modification, like statins. Carotid artery disease, die from CAD. Repeat and augment. Carotid artery disease, die from CAD. So again, vascular disease here means vascular disease here. So we should check it out. So someone with a bruit, check out an ultrasound, or if someone's had a TIA or a stroke, check out the ultrasound of the carotid arteries. And if you can't get a good image of the carotid arteries with the ultrasound, think about doing CT or MRA. And here is an example of a high-grade stenosis, 90% of the internal carotid artery here. So how should we treat them? Again, remember, think about them as coronary artery disease, so your aspirin or clopidogrel, or you can also use aspirin and extended-release dipridamol. Get the blood pressure under control, statin them, and of course get them to stop smoking. Now, the only class 1 indication for sending someone to get fixed is this. So if they have had within the last 6 months, a TIA or a non-disabling stroke, and by ultrasound on the ipsilateral, that's ipsi same side, so on the same side that the stroke happened, they have 70% or more stenosis by ultrasound, non-invasive, or 50% by catheter angiography. Then, and they've had, as I said, the symptoms in the last 6 months, you should refer them to either stent or surgery. The surgery, the endarterectomy, it's great, but you remember they're under general anesthetic, there's a lot of blood loss and that, so there's higher rates of having a heart attack during that surgery. Whereas if you do a stent, we go in through a catheter, they're awake. So there's less MI, less stress on the heart. But when we inflate the stent, even though we use kind of different catcher devices and things, still we have the issue of some of the plaque sometimes breaks off and goes to the brain. So they have more chance of stroke with doing the stents. And then, of course, because this is a stent, they'll need aspirin and clopidogrel, typically for 1 month. So the mantra here, guys and girls, let's just do this one. 70% non-invasive, 50% angiography, plus symptoms equals surgery. Repeat and augment. So that is the only class 1, which means the boards will probably ask you about this. So let's have a question. A patient with a TIA a month ago has had an ipsilateral internal carotid artery stenosis of 75% on ultrasound, should be referred for carotid endarterectomy or stent placement. Is that true or false? I'm feeling my 100% vibe coming on here. Okay, well, I'll take 97. So yes, the answer is yes. Remember, they had 70%. They had the symptoms within the last 6 months. They should be referred for endarterectomy or stent placement. So the answer is true, and you should not sit on them because the chance of them having another big one, just like if we sat on someone who had a problem with their coronary artery of having a big one, is increased. Okay, now, cerebral embolic disease. Let's talk about cardiac cerebral embolic disease. AFib is the most common in terms of the etiology of this. There are other causes, but AFib is the big one. So even if you get someone in, they have a mini stroke or something like that, it's an elderly person, you might bring them in, there's normal sinus rhythm, you do heart, carotids, everything's normal. Most likely it was AFib, so make sure once they're discharged, check the Holter and maybe even consider a 30-day cardiac event recorder. That will improve the detection of AFib 5 times over the Holter. And if you don't find anything, you've got to put them on some antiplatelet. You've got to assume it is some thrombus from somewhere, aspirin or clopidogrel or aspirin and extended release dipridamole. Okay, aortic disease. Let's talk about aortic disease. And hopefully you recognize that aortic aneurysm there from our lecture at the start of the lecture. And you've got the Ehlers-Danlos syndrome person there with their elongated face, thin nose, and the large eyes, easy bruising, including vascular problems as well, rupture of arteries, and then the Marfan syndrome. So let's talk first about thoracic aortic aneurysm. So thoracic aortic aneurysm is, any hypertension is a risk factor for any aneurysm, just as a FYI. In particular, there are some specific other ones for the thoracic aneurysm. Marfan's, Lewy-Dietz, vascular Ehlers-Danlos, bicuspid aortic valve, coarctation of the aorta, familial thoracic aortic aneurysm and dissection, and pregnancy the 3rd trimester are independent risk factors for developing a thoracic aneurysm. So dissection. With dissection, it's, absolutely, this is kind of like the worst pain they have ever felt. I had a patient when I was at the Mass General Hospital who told me it was like, the pain it was like, they said, imagine your body is a sheet of paper or a tissue, and someone is trying to tear your body in half. They said that's what it felt like. It was literally like someone was tearing them, ripping them, trying to rip them in half. So with acute dissection, it's not like, oh yeah, I'm having a little bit of pain, this and that. It's really, really severe pain. And typically, it'll happen in the front, and then they will report it's now moving to the back. Oftentimes, they'll come in, their blood pressure's out of control as well. They may present also with syncope, with heart failure, or even a stroke. So a little trick that may help you out is check the plasma D-dimer. Now, sometimes the boards, on the labs, click here for labs, they will actually have this in there. If the plasma D-dimer is under 500, that rules out dissection. It is not an aortic dissection. And importantly, it also rules out PE, which is something that's often on your mind with someone coming in with, severe and violent kind of onset of chest pain. So what you want to do for these individuals, if they're not in shock, you want to lower the heart rate first. So first beta blocker, then you add your vasodilator, for example, nitroprusside. And that will, if you do it in that order, that will reduce the chance of getting the reflex tachycardia. So with the type A dissection, remember that's ascending, those have to go to surgery. But with the type B now, we can actually treat them medically, which is quite nice. And, okay, so you're following your patient out in clinic with that has a thoracic aortic aneurysm. When should you refer them to surgery? If once the aneurysm gets to 5.5 centimeters in size, if it expands more than half a centimeter in 6 months, or if you're following them annually, 1 centimeter in a year, and then finally, if they have symptoms from compression of nearby structures. So the mantra here, guys and girls, greater than or equal to 5.5, greater than 0.5 and 6, symptoms, slash them. Repeat and augment. Good, okay. Now there are some slight changes in terms of the 5.5 for certain individuals. For example, Marfan's and some people with bicuspid aortic valve and valvular disease, it's a little bit less than that, but this will cover most of your patients that you are seeing for the boards. And the reason I like that is the same as the criteria for abdominal aortic aneurysm. The main difference for abdominal aortic aneurysm is the risk factors are different. It's the systemic hypertension, male smoking, emphysema, cholesterol, obesity, and genetics, mainly in 65 to 75-year-old males. Now, the good news here is that 80% of them that are 5 centimeters or over, you can actually palpate. So for your men who are 65 to 75 who have ever smoked, check that out. Check the abdomen out. And as I said before, the mantra is still the same, greater than or equal to 5.5, greater than 0.5 and 6, symptoms, slash them. That's when we should refer them to surgery. And here is an example of a nice juicy aneurysm that is going to be needing surgery. Now, the good news is we have different options for surgery these days. In the old days, it was pretty big, major surgery. Nowadays, we can actually do what's called endovascular aneurysm repair, or EVAR. And it's basically the stent is acting like a sleeve. So here is the classic infrarenal, or you can do it with common iliac. So here's the aneurysm. And what we do is we essentially put in this stent, and the newer ones actually have, it's like a pair of trousers stent. It's with 2 legs. We put the stent in, and then we inflate it, and now the blood goes down the stent. And the aneurysm is basically, kind of like shut off from blood flow. So the nice thing is, it's pretty good. It works in most people, and the 30-day morbidity and mortality for EVAR is significantly lower than open surgery. But there is this thing here, the bane of the endovascular aneurysm repair folks is this thing called endoleaks. And what this means is nature somehow finds a way. So even though we've got the stent in, somehow blood sometimes finds a way back into this aneurysm and it continues to grow. It happens in about 10%, so there is still a risk of rupture of 1%. But the good news is, in 90% of people, the aneurysm is shut off here, the blood, you get stasis, it fibrosis, clots, end of story. And of course, they'll be on dual antiplatelet therapy, and we check them for the endoleaks annually. Okay, the U.S. Preventive Services Task Force, let's talk about them. I mean, this is the most, conservative body in the United States. I mean, I'm talking, drinking port, sipping on smoking cigars, men's clubs and all the rest. And it's like, oh, but for the days of Oslo. Oh, yes. Oh, and these residents these days. Oh, yes, it's shocking. Have you seen them? I round in the morning and then someone says, I say, please tell me about the patient. Oh, but excuse me, sir, I was not, the night float admitted that patient. And so I don't really know much about that. Shocking. Oh, and the horrors of technology. Yes. Have you ever tried pimping them these days? Yes, it seems like they always have to make urgent calls on their phones and they always get it right. Oh, the horrors of technology. Well, the good old boys would like to turn back time, but that may or may not happen, but they are pretty connected, the good old boys. And so when the US Preventive Services Task Force, so their normal response, anyone who says, oh, look at all these studies, isn't that a good idea? They're like, insufficient evidence. Go back and do more studies. Rejected. So their normal response is to pretty much reject everything that everyone says is a good idea. Now, once there is overwhelming evidence and they can no longer save face and reject it anymore because everyone is saying, all of the cardiology bodies, all of the internal medicine, they're all saying, look, it works, we need to do it. Then they finally do it. So one of their recent proclamations of 2005 was for abdominal aortic aneurysm screening. This is a Class 1 US Preventive Services Task Force recommendation, a one-time screening for abdominal aortic aneurysm by ultrasound in men who are 65 to 75 years of age who have ever smoked. And hopefully you recognize there the smoking man from the X-Files. So hopefully he got his abdominal aortic aneurysm screening. I can tell you in my clinic, I have a cardiology clinic a couple of times every week, and at least one patient every clinic, I have the fellow or the resident order this, and we have picked some up. So now, because the US Preventive Services Task Force have said you should do this, what happens if you don't? So let's say you don't, and your patient goes and ruptures their aneurysm, and let's say worst case they die. They will get a lawyer who's an expert in this, and they will bring a lawsuit against you, and they will bring you up and they will say, doctor, you saw this patient, you knew that they were a former smoker, he was 68, why did you not check him for abdominal aortic aneurysm? And you'll be like, really? I was supposed to do that? And they will take you to the cleaners. That's the only problem with the US Preventive Services Task Force. Once they've given it their gold stamp of approval, it is considered not only standard of care, but standard of care so high, if you don't do it, you will be fried. And I don't want any of you guys and girls getting fried, okay? Particularly by the internal medicine boards. Let's talk about infective endocarditis for a little bit. Unfortunately, us guys, it's more common. So more likely for us guys, infective endocarditis. And we have staph is the it bug for endocarditis these days. So front page of Bacterial Newsweek, staph. Front page of Bacterial Vogue, staph. Front page of Bacterial MTV, staph. Front page of, what other magazine? Rolling Stone, Rolling Stone, staph. So staph is the it bug for endocarditis. It is the #1 cause of endocarditis for native valve, Staph aureus, for prosthetic valve, coag-negative staph, like, for example, staph epidermidis, and for cardiac implantable defibrillators and other devices, again, Staph aureus or coag-negative staph epi, for example. So staph is the it bug. If you've got someone who comes in with infective endocarditis, get your blood cultures and then do your echo. Now, again, a lot of people say, oh, should I be doing the transesophageal? No, start with the transthoracic. In fact, you will get most of them on that. Obviously, the TEE is if you suspect it and there's other signs of something going on, or you're suspecting there's some complication, go for it. But always do the transthoracic first and then do your modified Duke criteria. And the modified Duke criteria include bacterial endocarditis at 5 p.m. That's my little mnemonic, because they always come in Friday night or Saturday night, 5 p.m. Just when everyone's about to go home, that's when they come in. So major criteria, bacterial, so if their blood cultures are positive for the usual guys, suspects, endocarditis, if you see evidence of endocarditis on the echo, positive echo. So that is, they're the two major. If they have the two major, Duke criteria positive. You don't have to do any further studies, you've got it. If they have all 5 minor criteria, so fever, immunologic phenomena, vascular emboli, predisposition or microbiological evidence, all 5, then they also meet criteria. And then finally, a lucky number 13, if they have 1 major and 3 or more minors, they meet criteria for modified Duke. And you note that in your note, positive endocarditis based on modified Duke criteria treatment. That's it. You don't have to do any further sophisticated studies once you got the diagnosis. Just treat them. You might find some things on the physical exam. The Janeway lesions, they are flat, painless lesions of the palms and soles. Splinter hemorrhages, these are thought to be tiny little thrombi that were on the endocarditis in the heart that broke off and went either to the fingernails or to the toenails. So they're thought to be thrombotic. Let's talk about Osler's nodes just for a moment. So once I finish my work on the flux capacitor and go back in time in the time-traveling BMW 3 Series, I'm going to head back to Hopkins and spend some time with the Big O. Because, he was a legend on physical exam, particularly cardiac exam, named a lot of things. But then I read his biography, just recently, and my gosh, rounding with the Big O. So first of all, you had to dress up full formal attire. I'm talking tails, polished shoes, the rest. That was the dress code to round with the Big O. So I don't like doing that, so that would be a problem right there. Secondly, the Big O put the P in pimpology. Think of the worst pimper that you've ever met or you've experienced. They were nothing. The Big O was just the Terminator. He made grown men and women cry. He was just... So I was thinking, okay, I'd be back with the Big O, time traveling, we'd be on rounds, and the Big O would say, Mr. Higgins, tell me of your findings on the physical exam of this patient. And I'd be like, okay. Dr. Osler, I hear a 3/6 decrescendo murmur at the left upper radiating to the left lower sternal border. I also see signs of a water hammer pulse peripherally, a Corrigan's sign, and pistol shot femoral pulses. And I'd be feeling pretty good about myself. And this is all consistent with moderate to severe aortic regurgitation. Mr. Higgins, very well, but would you please continue on and tell me the other 11 physical findings that you haven't yet mentioned in this patient? I'd be like, So, can you imagine, guys and girls, what it would be like to round with the Big O? How painful that would be? Just like Osler's nodes. Painful raised lesions on the hands and feet. Okay, Roth spots. Now, in the boards, they may say, they may give you a patient with fever and positive blood cultures or something like that, and they say, as an ABIM board-certified internist, you perform ophthalmoscopy like you do on all of your patients. And this is what you see. Click here. And they may show you this. Now, they may or may not have done that in the MOC that I recently did, but I cannot confirm or deny it. And then they may ask you, well, what's going on? And if you see this classic ophthalmoscopy here that shows the retinal hemorrhages with the white centers, it's red, white, and blue, very like our patriotic buddy here. Red, white, and you will be blue because your patient has endocarditis. So what about endocarditis with early surgery? There are some individuals we need to get them to the surgeons pretty quickly. So if they've gone into heart failure, that's obviously a sign. If they've got really nasty resistant organisms that are not getting better despite your antibiotics, if they've got a heart block, or they're having emboli, or you've got a prosthetic valve that's infected, again, they are not normally going to need to go to get it physically removed, unfortunately. Cardiac implantable electronic device infections. This means pacemakers, ICDs. We're putting a lot more of these in. And the mantra here, guys and girls, when infection is not in doubt, take it out. Repeat and augment. So, unfortunately, we're putting a lot more of these in. We are going to be taking a lot more of these out. So if you have someone who has an infection and it's on the lead, you do the echo and you see it on the lead, or it's in the pocket, there's an infected abscess or something in the pocket, or they have like a mitral endocarditis, for example, and they have to have a device in, or occult staph bacteremia. So you've checked all the usual places, you can't find any of it, your echo looks okay, but they're still having staph. The device has to come out. So unfortunately, you're going to be seeing more and more of that. Antibiotic prophylaxis. We used to do this on a lot of people, and the main thing for you guys to know these days is we only do it, number one, on high-risk patients, which I've listed there, prosthetic valves, previous infective endocarditis, congenital heart disease that are either unrepaired or partially repaired with shunts still present, or cardiac transplant, and only if they're going essentially for the dentist or oral surgery. So teeth, gingiva, oral mucosa. So you got to meet those two criteria now. That's it for endocarditis prophylaxis. And I just tell people to remember either the amoxicillin-based or if they're penallergic, clindamycin, about 30 to 60 minutes before. Let's turn to the valvular disease. This is our bicuspid aortic valve ventricle singing. Push it. Because he's having to squeeze a lot harder to get the blood out of this tight bicuspid aortic valve. So the ventricle's gotten a lot more hypertrophied compared to this normal, beautiful tri-leaflet tricuspid valve. This is the most common congenital cardiac abnormality, is you're seeing here. 1% of people, so probably someone in this room has one of these or knows someone closely who has one of those. Importantly, the murmur peaks after mid-systole. So with aortic stenosis, who should we send to surgery? Those who have severe aortic stenosis, which is defined as an aortic valve area less than or equal to 1 centimeter squared. Remember, the normal aortic valve area is about 3 centimeters squared. So they've gotten very, very tight stenosis here. And we do an echo, and we show a velocity of 4 meters per second or higher, or a mean peak gradient of 40. Now, what about if they're severe aortic stenosis and they tell you that they're asymptomatic? Well, if they have an ejection fraction that's less than 50% and they have the 440, even if they're asymptomatic, they should be referred for surgery. A question comes up sometimes where you'll have someone who you're not sure, they have a very low ejection fraction. So for example, their ejection fraction might be 20% and there's not much blood going across the aortic valve. And the question is, well, is it because, the heart is not pumping much, so the valve's not opening a lot, not much blood is coming across? Or is it that they truly do have severe aortic stenosis? So the answer to that, to determining that, is you actually do a dobutamine stress echo on them. You essentially restore that 20% ejection fraction back to 60%. You actually just stimulate the muscle with dobutamine. It pumps harder. If at any time during that stress test they hit the 440, then that's true severe aortic stenosis, not pseudostenosis, and they should go to surgery. TAVR is the new kid on the block, and TAVR is shown here, and we are now using it for high or intermediate risk patients. So first thing we do is we put a balloon up, and then we crack open the valve leaflets. Then we insert this special stent, and this is not just an ordinary stent. This is super stent, because when we inflate the stent, inside pops open a new valve, and this is transcutaneous aortic valve replacement. Or transcatheter. It's getting a lot more popular. Acute aortic regurgitation. This again is where the blood is going back acutely the wrong way. So you should have a high index of suspicion if they have the setup for acute aortic regurgitation. And the setup for that is endocarditis, trauma. So, they might have been in a severe car accident where they got trauma to that aortic valve, or aortic dissection. And they come in basically in extremis. They have, all of a sudden, blood is going the wrong way. They come in, they're often in pulmonary edema. So what you want to do is they need urgent surgery, but in the meantime, give them dobutamine to help the heart pump more blood out, so more is going forward, and also a vasodilator as well. So again, it's easier for more blood to go forward, less blood will go backwards. And this is an example of an endocarditis causing that problem. Chronic aortic regurgitation. So with chronic aortic regurgitation, again, any problem with the valve or aortic root, typically they'll have this increased pulse pressure. That will be the kind of tip-off. So for example, the difference between the systolic and the diastolic is very large. And they may have these peripheral findings like Waterson's water hammer pulse, or Corrigan's that I was telling Dr. Osler before about. So when to do surgery on these individuals? Well, again, if they have severe aortic regurgitation, in fact, for any valve condition, most people who have a severe version of it, most of the time they're symptomatic. You know, they might tell you they're, oh yeah, I'm asymptomatic, but you know, get them on a treadmill after 3 minutes, they're probably going to be huffing and puffing. So severe valve disease, most of them are going to need to be referred to surgery. For the asymptomatic severe chronic aortic regurgitation, those individuals, if they have an EF less than 50% at rest with no other cause, they should go. Also, if they have a dilated left ventricle, they should go to surgery as well. Let's now talk about mitral stenosis. So mitral stenosis, you can see here, this is a classic case of rheumatic mitral stenosis with these, this is the mitral valve leaflets here with this hockey stick appearance, and big left atrium and little left ventricle here. And you can see in the old days, we used to have to go in there surgically and kind of cut apart these valves, which were kind of fibrosed and stuck together. But these days, we can do it transcatheter. So still, the commonest etiology of severe mitral stenosis is acute rheumatic fever, which is in turn caused by group A beta hemolytic streptococci, so strep pyogenes. So not, here's the, you know, for chronic mitral stenosis, rheumatic fever, this is not staph, this is strep. This is the commonest cause. And oftentimes they'll give you a story. They'll be from, you know, a third world country. They will have a story of developing rheumatic fever when they're in the teens, for example, and they will show up to your office about 20 years later. That's the typical delta, commonest being mitral stenosis. And they'll tell you, you know, they've been on aspirin, they may even still be on penicillin or erythromycin, they've been on it for years and years. So that's the etiology. Okay, so question. Acute rheumatic fever is usually caused by staph, influenza, group A, beta hemolytic strep pyogenes, or Pseudomonas. Let's see how the 100%ers are working. Okay, so yes, group A, beta hemolytic strep pyogenes is the commonest cause of rheumatic fever. Staph is not. Staph is a commonest cause of endocarditis. Influenza virus is not. That causes flu, and Pseudomonas is not. That causes infections in people with cystic fibrosis and hospital-acquired infections. Okay, so mitral stenosis, the physical exam for mitral stenosis. Remember, mitral stenosis, MS-DOS, the old operating system, mitral stenosis, diastolic opening snap. So that is the key physical findings with a rumble. The classic chest patient will come in with fatigue, exertional dyspnea, orthopnea, often AFib because they've got that big atrium. And the X-ray will show this lovely triad of enlarged pulmonary arteries, because remember they've got high pressure backing up onto the pulmonary system. They've got the big, large left atrium. Normally the left atrium doesn't poke out like it's doing here. And they have symptoms despite the normal sized LV, and this all points to mitral stenosis. Okay, so question time. A 37-year-old Pakistani woman presents with fatigue, exertional dyspnea, and orthopnea. She tells you she had a bad infection in her teens and has a heart murmur now. So here's her chest X-ray. So the question is, what does she have? Pulmonary embolism, atrial myxoma, aortic aneurysm, and mitral stenosis. So 37, had a bad infection in her teens, got a heart murmur now. Okay, so most of you guys are on the money. So she is a classic mitral stenosis with acute rheumatic fever history. She doesn't have a PE. I mean, this was dyspnea on exertion, and this was a chronic thing, and also does not have the physical findings of that. Atrial myxoma, no, this would not be consistent with someone who had an infection in their teens and now is presenting to you 30 years later. So that is incorrect. Chronic severe mitral stenosis. So with chronic severe mitral stenosis, these individuals, the definition of severe mitral stenosis now is a mitral valve area less than or equal to 1.5 centimeters squared. And the good news is, if it's someone, particularly if it's with rheumatic mitral stenosis and they're younger, as long as they don't have any left atrial thrombus or they don't have moderate to severe mitral regurgitation and they have a Wilkins score of less than or equal to 8, which is a special echo score we use. Again, the higher the score, the more calcium and the more deformities of the leaflets, then they can actually go for percutaneous mitral balloon commissurotomy, which is kind of cool, which you can see it here. They go in with a catheter, put the catheter across the stenosed mitral valve, and then they inflate a balloon and essentially crack the leaflets apart. And it works really, really good in most people, and most people only need it once. If they are not candidates for that, then obviously you need to repair them. We prefer repair if possible, or do a mitral valve replacement. Acute mitral regurgitation. Well, acute mitral regurgitation, again, just like acute aortic regurgitation, it may be related to endocarditis, trauma, but a commonest cause actually is these individuals that have myxomatous chordae, which are these really thick cords and associated with mitral valve prolapse, and they tear, and this is the commonest cause of acute mitral regurgitation. And they will present with shock. Again, all of a sudden, everything's going the right way, and then all of a sudden now everything's going backward, the wrong way. So they present in extremis, shock. You want to, again, help the heart to pump more blood forward and vasodilate them, so more blood goes forward and less goes backward. And importantly, bless you, you also put in one of these. This is an intra-aortic balloon pump. This will help, by its suction and other mechanisms, pull more blood out and forward into the heart while we get them to the OR. Again, acute AR and acute MR need to go urgently to surgery. Chronic mitral regurgitation. Well, in this, here's a echo showing here's the left ventricle contracting, and you can see all of this blood going back into the left atrium abnormally. So a picture is worth 14 words, so it can be a problem. Anything from the mitral annulus to the leaflets to the chordae to the papillary muscles to the left ventricle, or a combination of any of those can result in chronic mitral regurgitation over time. So the 30-40 rule with chronic mitral regurgitation, when should we send someone to surgery? First of all, again, if they're really symptomatic and as long as their ejection fraction is still over 30. If you've waited too long and their LV's failed and now it's less than 30, oftentimes people will not take them to the OR because they can't get them off the heart-lung machine. What about asymptomatic patients? So an asymptomatic patient with severe mitral regurgitation, as long as their ejection fraction is 30 to 60%, and this is where the 30-40 rule comes in. If you look at their left ventricular end systolic dimension, so what is that? So remember, systole is contraction and diastole is relaxation. So normally, the left ventricle, when it contracts really good. It normally contracts down to, 20 or 2 centimeters. If the left ventricle starts to fail, it can't contract in as much. And so at the end of systole, it's now, if it's 4 centimeters or 40 millimeters or more, then that is really severe damage. And you want to get that person, even if they're asymptomatic, to the OR. So remember that number. That may come up in a question soon. We prefer mitral valve repair, if we can, to replacement. Some of your institutions, including ours, are doing the MitraClip now. So if someone's a really high risk for surgery and they won't be taken, here is someone with severe mitral regurg. You can see the severe jets. They basically put this little clip. It's almost like kind of a super paper clip over, and they clip it on the valve, and then they reduce the regurgitation. So that is a possibility for some individuals. Okay, question 18. A 51-year-old man presents with a murmur. He's inactive, has a desk job, and uses the elevator. He denies symptoms, but reports he doesn't exercise. He's a bachelor and watches movies and drinks beer on the weekends. So his physical findings, the main thing is he's got this 4/6 systolic murmur, loudest at the apex. You do the echo, his EF is 45%, and he has a left ventricular end systolic dimension of 4.8 centimeters. That is abnormally large. So the question is, what do you want to do for this patient? Do you want to start him on lisinopril? Do you want to refer for mitral valve repair replacement? Start nifedipine, follow in clinic closely, or refer for percutaneous balloon commissurotomy? Okay, good job. You guys are on it. So refer for mitral valve replacement repair. This guy's got a dilated left ventricle. He's already started to fail. You don't want to wait. So that's why C is not correct. You don't want to wait. You need to send him now. Otherwise, his EF will continue to fall and he may not be a candidate. Prosthetic heart valves. Let's talk about that. The younger people under 50, we want to give this mechanical, like a St. Jude or something, because that will last a lot longer as long as they can take anticoagulation. For the older people over 70, we generally go with a bioprosthesis because we know that oftentimes those individuals will have problems with anticoagulation. And then in between, depending on patient factors. The main thing that I want you guys to take away from the new guidelines is for antithrombotic therapy. It is now dual therapy. That is Coumadin and aspirin. So Coumadin and aspirin, baby aspirin, on everyone who has a mechanical valve. That is the new guidelines. Okay, question. A 60-year-old woman just underwent valvular surgery. Mechanical valve was placed in the mitral position. She's otherwise healthy, does not take any medicines. You hear a nice crisp mechanical S1, normal S2 with no murmurs. So what antithrombotic medication should she take? Okay, good. Okay, most of you got it. So she should be on now. She's a mechanical. The new guidelines, warfarin and aspirin is correct. Clopidogrel and aspirin is not correct. That's actually not indicated. And so she should be on warfarin and aspirin. What about surgery with these individuals? Occasionally, we do have to take them to surgery if they are having a minor procedure. If you could just continue everything if it's something minor. If it's more major, we stop it for 5 days. If it's an aortic valve, we just let them drift down. But if it's mitral, we generally do bridging. But the good news is we can use subcutaneous low molecular weight heparin as well. Sometimes they might get thrombosed, so do usual testing for thrombosis. We fibrinolyze them, and bioprosthetics, you can just start them back on Coumadin. There are some other options as well, but when in doubt, consult it out. Lecture 4, we're going to be talking about some of the arrhythmias as well as heart failure and tamponade. So let's start with the arrhythmias. So just a couple of general principles. Most of the arrhythmias are going to be re-entrant, back or again, enter. So they're kind of like a cyclical type thing, whether it be in the atria, the ventricles, or in the AV node. Narrow complex generally are going to be supraventricular. Holter monitor is where we normally start with most people, and then we can move on to other tests as needed. In the supraventricular system, the people are represented by two separate yet equally important arrhythmias: atrial flutter, which is regular, and atrial fibrillation, which is highly irregular. These are the stories. Boom, boom. So, atrial flutter. This is going to be you can see the flutter waves represented on the ECG here. Typically, the atrial rate is going to be around 300, and the ventricular rate is going to be lower than that. And so, classically, you will see the sawtooth pattern in those inferior leads. The classic one is the type 1 or the cavo-tricuspid isthmus dependent. Essentially, you've got this counterclockwise circuit running between the inferior vena cava and the tricuspid valve, going around about 3 times per second. Treatment nowadays, we treat AFib and A-flutter basically the same. Again, if they're acutely unstable, you want to cardiovert them, and if they're not, then you can use medications. The good news with flutter is that catheter ablation has a 95% success. So, typically with flutter, first-time flutters, we'll just cardiovert them and get them back. But if they come back in, and especially if they're symptomatic, despite, the medicines we've got them on, then send them for catheter ablation. As I said, 95% success. Oh, question 20. A 76-year-old female was diagnosed a month ago with atrial flutter and underwent cardioversion to normal sinus rhythm. She now reports palpitations have returned, is fatigued and unable to exercise. She doesn't like it. ECG today shows recurrent atrial flutter. Ventricular rate 71. She's got high blood pressure, heart failure, preserved EF, diabetes. She's on apixaban, metoprolol, lisinopril, metformin, and rosuvastatin. So despite, having a good ventricular rate control, she's really, really symptomatic. You check She's got an irregular pulse. You've got a echo post-cardioversion, showed EF 55%, left atrial dilatation, diastolic dysfunction. Nuclear stress shows normal perfusion in EF. So the question is, with now, she's got this recurrence of atrial flutter. What would you like to do now? Do you want to cath her, cardiovert her, send her for catheter ablation, or do nothing? And she seems to be very symptomatic despite the medicines you've got her on. Excellent. Most of you guys got the right answer. Yes, I mean, you know, the boards say basically if you've already tried once and she's back into it, I mean, more than likely if you cardiovert her again, she's going to be back, you know, next month, same thing. So that's why B is no longer indicated here. Catheterization, I mean, there's no indication for catheterization in this person, and she had a normal nuclear stress test. So you want to refer her for a flutter ablation. Again, 95% successful in this population. Atrial fibrillation. So atrial fibrillation is similar to flutter in that there are little circuits, but there are multiple little circuits all over the atrium. And they have, you can see here on the ECG, often it's kind of in a regular baseline, and sometimes you can see these waves here, we call them F waves, because they're totally effed up. Actually, we call them that, they're fibrillatory waves. And literally, these are these little tiny circuits going around and around, causing these different little fibrillatory waves. So this is classic atrial fibrillation. We have different names for it depending on how long it is around. Paroxysmal, under 7 days. Persistent, over 7 days. Long-standing, persistent, more than a year. Permanent is basically continuous. And importantly, because most AFib is related to mitral valvular disease and left atrial issues, then these are mostly caused by that. However, there is this subgroup, non-valvular. So you have no mitral issues, no mitral valve disease, or mitral valve repair. So for rate control, there's two things for AFib, rate control and anticoagulation. For rate control, per the new guidelines, strict rate control is considered 80 beats per minute on average at rest, or 110 during a 6-minute walk. So you want to get those people, when you're in hospital, try to get them down to a resting heart rate of under 80. Now, if let's say they really want to go home, they said, I'm going home today, doc, no matter what, and let's say their heart rate is 90, as long as they have an ejection fraction over 40 or higher, and they're not symptomatic and they can walk around okay, it's reasonable to send them home for that. So acute atrial fibrillation, we want to control them with beta blockers intravenously or calcium channel blockers, and DIG and amiodarone. For chronic AFib, again, the same medications, but on an oral basis. If they have heart failure, we particularly like metoprolol succinate and carvedilol, as well as calcium channel blockers. And if they have heart failure, reduced ejection fraction, other options to the beta blockers include dofetilide, digoxin, and amiodarone. And then finally, if they're unstable AFib or any SVT for that matter, then we want to blast them. So if they're having chest pain because of the AFib with RVR, or if they're hypotense or heart failure, despite what you're doing, you need to urgently synchronize cardioversion them. So let's have a look at this question. A 25-year-old female soccer player comes to the emergency department. She reported having palpitations and nearly passed out at soccer training 15 minutes ago. Her blood pressure is 70/40. So here is her ECG. And the question is, and her blood pressure is 70/40, what would you like to do now? Do you want to give her IV diltiazem, IV esmolol, synchronized cardioversion, or IV digoxin? And your ECG should be in your book as well if you need to take another look. Okay, so you guys, most of you guys are on the money. So she is hemodynamically unstable AFib. She's 70/50. She's got a very fast rate. You need to cardiovert her in the emergency room. IV DILT and esmol are contraindicated because her blood pressure is she's already hypotense, and IV digoxin will not do anything for this fast heart rate. Remember, with DIG, you always have to use it with a beta blocker or calcium channel blocker, which again are contraindicated in this situation. Amiodarone. Now, amiodarone is a good drug, and my med students particularly like this. You know, I tell them, okay, when your attending asks you what are the contraindications to amiodarone, just look them straight back in the eye and just say, what a bitch. Shock and awe, that's what I tell them. Now, the attending will be like, oh my God, I've got a psychotic med student on my team this month. What am I going to do? And while they're kind of thinking about that and they're kind of lost focus, then you can say, you know, B for bradycardia, B for blue man syndrome. Don't forget the sunscreen. I, interstitial lung disease. I for increased QTC interval. T for thyroid, hypothyroid being more common. T for tremor. C for corneal microdeposits. And cytochrome P450 inhibition, which means you have to drop the doses of some medications. And then finally, H for hepatic and hypotense, especially with IV amiodarone. Rate control versus actually rhythm control. Well, the studies are in, starting with AFFIRM and other studies, no difference, amazingly, in most people. However, there is a small subgroup of people that are very, very symptomatic. They know exactly the second they went into atrial fibrillation, and they hate it. They can't do anything. You know, they can't sleep because they're hearing the blah, 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 blah in their ear. They can't do it, you know, they can't work. They can't sit, they can't concentrate. And so these individuals, we try to get them back into normal sinus rhythm. We cardiovert them either electrically or chemically, and then we try to maintain them with either a class 1 agent or a class 3 agent. Now, if you're not sure what, you don't have the echo back, you're not sure what their structural heart disease, a good med to use as a first line is amiodarone in this situation until you get information back. Anticoagulation. So this is the other part of AFib. There are 3 different categories for anticoagulation. The first is lone AFib. So this is literally they have atrial fibrillation by themselves, nothing else. And in these individuals, you don't have to do anything if you don't want to, or you can do aspirin, just a baby aspirin. If they have valvular atrial fibrillation, they need to have Coumadin. And that also includes anyone who has hypertrophic cardiomyopathy as well, or a valve. And then finally, if they have non-valvular AFib, this is when we use the CHADS-2 VASC score to figure out what to do. And here is the CHADS-2 VASC score. Here, CHF, any history, or LVEF less than 40%, hypertension, age greater than 75, 2. Diabetes, stroke, TIA or thrombolism, 2. Vascular disease, age 65 to 74, 1, and sex category female, 1. If they have a CHADS-2 VASC of 0, nothing. 1, aspirin, or nothing. And then 2 or higher, that's when you have to do warfarin or your NOACs. Or if they are really, really high risk of bleeding, you can consider a left atrial occluding device, like the Watchman. So for these, you can check out the HAS-bleed score. If the HAS-bleed score is 3 or higher, have some caution. But honestly, what most of us do, because let me tell you, if someone has a big stroke, it's a big, there's some studies, 50% mortality within 1 year after they've had a big stroke, especially if they're bedbound. So what I normally do is I put them on the NOAC or the DOAC, and if they do have, a fall, or if they do have a GI bleed, most of the time they come into hospital, they have to get a bit of blood or something, then I will just put them on aspirin or something like that. And of course, have a discussion with them. But remember, stroke, the best way to reduce stroke is Coumadin or the NOACs, DOACs. So the dabigatran or Pradaxa is probably the first line agent for a lot of people. D for dabigatran, D for direct thrombin inhibitor. And this is indicated for anyone who is a CHADS-2 VASC of 2 or higher with AFib or A-flutter, and they either cannot take Coumadin or they refuse to take Coumadin. And the standard dose is 150 milligrams BID. If they have reduced renal function, we have that dose. We can't use it if they have really severe renal function or they're on dialysis. The other agents that are on that list, rivaroxaban, apixaban, and edoxaban. So my little mnemonic here is RAFE. So Rivarox, Apix, Edox, they are the factor 10A inhibitors. And the one I would point out to differentiate here is apixaban or Eliquis. A for apixaban, A for age greater than or equal to 75 or high risk for anemia, so bleeding, or acting up kidneys. So this is the only one that is indicated for individuals that are on dialysis or have complete loss of kidney function. Apixaban. It's been found to be better in elderly individuals, and it's the only one that actually has a lower or similar risk of GI bleeding to Coumadin. All the other DOACs have higher risk for GI bleeding than Coumadin, but this one doesn't. Okay, question 22. A 67-year-old African-American female patient with permanent atrial fibrillation comes in. She's taking metoprolol succinate for rate control and lisinopril for hypertension and metformin for type 2 diabetes. Her labs are normal, including normal renal function. She refuses to take Coumadin. What do you recommend now for her anticoagulation? So hopefully you've done a little CHADS2 VASC score there. Do you want aspirin and combo, aspirin, regular aspirin, dabigatran 150, dabigatran 75, and clopidogrel 75? What would you like in her case? Is our 100% going to appear here? Wow, okay, good. Most of you guys are on the money. So she is a CHADS2 VASC of what? Yeah, I mean, it's over 2. So she needs to be on a DOAC or Coumadin. So the only DOAC or Coumadin here are C and D, and she has normal renal function, so she gets the normal dose, 150 milligrams BID. Aspirin and dipridamol, no, that's not indicated. That is indicated for certain peripheral arterial disease and carotid disease, so that's wrong. Aspirin, wrong. That's only indicated if her CHADS2 VASC is 0 or 1. And clopidogrel, again, not indicated. No one got that. Great. So preventing thromboembolism in our individuals. So if someone comes in with AFib and AFlutter, and it's been more than 48 hours, typically what we'll do is we'll start them on some anticoagulation and then get them back, cardiovert them after 3 weeks, and then keep them on that for 4 weeks. Let's say that someone is hemodynamically unstable and they come in and we need to cardiovert them right then and there. Well, we cardiovert them because they're hemodynamically unstable. Then we put them on Coumadin or a NOAC for at least 4 weeks after the cardioversion. And then check, if they're maintained sinus rhythm. If they are AFib flutter, but let's say they have a really high risk of stroke, and you want to cardiovert them, but you want them on some sort of protection while you cardiovert them, well, you can either do IV heparin, low molecular weight heparin, or directed thrombin inhibitor or factor 10A inhibitor, do your cardioversion, and then per the CHADS2 VASC. Now, this is something that you do need to know. The boards like to ask you about this. That is, people with coronary artery disease that also have AFib. What do we do? So if they've had a recent ACS and a stent, that is, in the last year, and they have AFib, we have them on their dual antiplatelet, so aspirin, clopidogrel, and per the CHADS2 VASC. So that would be Coumadin, for example, or dabigatran. So they will be on triple therapy. If they have been stable with their coronary artery disease more than 12 months, so let's say they had a stent 3 years ago, and now, and let's say they're on aspirin and clopidogrel when they come in to see you, because a lot of people do take dual antiplatelet now chronically. So let's say they're on that, and now they're AFib. So what do you do? But the CAD is completely stable. You actually stop the aspirin clopidogrel, and then you start oral anticoagulation, either Coumadin or the DOAC. So this is something you need to know. This is in the new guidelines, and like I said, the boards may ask you, and I may ask you about it too. What about surgery? And they're on a NOAC or DOAC. What do you do with that? If it's minor surgery, like a colonoscopy, and they might be getting a biopsy, just stop it 1 day before. If it's more major, biopsy or spinal surgery, then stop it 2 days before their surgery. Okay, question 23. A 77-year-old woman is seen in for routine follow-up. She's been chest pain-free, feels pretty good. She had a stent 3 years ago. Again, is feeling great, no chest pain. Meds include aspirin, metoprolol, succinate, ramipril, and atorvastatin. Her vital signs are normal. However, she's got an irregular heart sounds. And you do an ECG, it shows AFib. Average ventricular rate of 72 beats per minute. She's asymptomatic with that. Which of the following is the most appropriate treatment for this patient now? add oral anticoagulation, add clopidogrel and oral anticoagulation, add clopidogrel, or stop aspirin and begin oral anticoagulation. Okay, good. Most of you guys are on the money here. Again, this is it's sort of tricky. Again, she's got stable coronary disease. So the guidelines actually say if she's now AFib, you can stop anything she's on for coronary disease, the aspirin and the clopidogrel, and then start her on oral anticoagulation, which is the correct answer, D. Now, adding clopidogrel, again, that is not indicated per the guidelines. Adding clopidogrel and oral anticoagulation, the reason we don't do all of this is that actually when you're on triple therapy, there is a significant increase in bleeding, including intracranial bleeding. And then finally, adding oral anticoagulation, again, increasing bleeding. So remember, you stop any of the DAPT, which includes aspirin or clopidogrel, and just begin oral anticoagulation. Occasionally we get, as I said, we get some people who are really, really symptomatic. These are the paroxysmal people. They know exactly when they come into it. They come in, they get cardioverted. So if they have had this happen time and time again, and you've tried either a class 1 or a class 3 agent, and they still are having the paroxysmal atrial fibrillation, in other words, they failed that, you can do what's called pulmonary vein isolation. So remember, there are 4 pulmonary veins that enter into the left atrium. They're the only veins in the body that carry oxygenated blood back from the lungs to the left atrium. So what they found is a lot of paroxysmal atrial fibrillation starts, actually, the little circuits start in the veins and then kind of spread down into the left atrium. So what they've done is they make almost like a fire break. They go in with a catheter and they kind of like burn or freeze around each of the bases of the pulmonary veins. So when the little wavelets start in the pulmonary veins and they move down toward the left atrium, they get to these fire breaks and it's like they burn out. They don't go into the left atrium. It's very successful. It's only indicated, however, paroxysmal atrial fibrillation, not for permanent. It's only for paroxysmal that is refractory or intolerant to at least one of the maintenance drugs. And importantly, too, they also have to have at least 2 months after the procedure of anticoagulation. So they have to be able to take Coumadin or a DOAC or NOAC as well. So if they can't take those, they can't be referred for pulmonary vein ablation. The other type of ablation that we do is for those people that are in AFib and the heart rate is all over the place and we cannot control them no matter what we do. Sometimes they're too low and they're dizzy. Sometimes they're too high and they're dizzy. And we've tried all sorts of medications and we just can't get them into the right rate control. And I'm sure you've all had patients like that. That's when we generally will kind of bite the bullet. We will go in and just take out the AV node and put a catheter, a pacemaker in so that we can control the lower rate. Set it at 60 so it will not go lower than 60, for example, and then put them on some medicine to control the rate higher. It works very well, improves exercise tolerance, ejection fraction, and quality of life. They still obviously need to be on anticoagulation because many of them, even if they're in sinus rhythm at the time, many of them go back in and out of AFib. Couple of special groups, whip it good. So if you've got Wolff-Parkinson-White syndrome and hemodynamically stable AFib, so these are the people that come in and they do kind of freak you out a bit because they're in AFib, but they're not in normal AFib, with a heart rate of 180. They are in AFib and they're going at like 300. They typically tend to be younger people, and sometimes you know that they've got the Wolff, sometimes you don't. You may see kind of a wide complexes or whatever. For those individuals, importantly, because they are conducting, the reason they're going so fast is they're using that accessory pathway. You don't want to do anything to affect the AV node, the normal pathway. You want to do everything so the normal pathway can take over because that will slow them down. So for those individuals, the drugs of choice are the whipperates. So iobutylide, procainamide, or amiodarone. Those are the class 1 for someone with hemodynamically stable AFib with Wolff-Parkinson-White really fast. If they, like our lady that came in earlier from soccer practice, if she's hemodynamically significant, very low blood pressure, obviously we cardiovert them. Thyrotoxicosis related or post-op, we can use beta blockers or non-dihydropyridine calcium channel blockers, as well as amio. And in fact, amio and beta blockers have been shown and are sometimes used in people that are going for cardiac surgery where there's a really high rate of post-op AFib. They've been shown to reduce AFib. Inappropriate sinus tachycardia, or IST. So this is a fascinating thing. To me, it's very interesting. It's where someone with a resting heart rate over 100, an average of greater than 90 on a 24-hour Holter. Interestingly, it's the most common in women in their 20s to 40s who are healthcare professionals. It's very, very interesting. And all of the other things have been excluded. So you've excluded thyroid, anemia, pheo, dehydration, pain, etc., and they're really symptomatic. So if they fall into that criteria, we do have a new medicine, the ivabradine. It actually slows, the nice thing is it slows the heart rate without affecting blood pressure. And the reason this is good, that we have this new medicine, is that traditional beta blockers and calcium channel blockers just make these people feel terrible. They may slow their rate down a bit, but they actually feel worse than when they were not on them. Ventricular arrhythmias. Let's talk about ventricular arrhythmias now. So the commonest ventricular arrhythmia that you probably see is just plain old premature ventricular complexes, or PVCs, also known as ventricular extrasystoles. So they have a wide abnormal QRS, a compensatory pause, and do you know that 75% of healthy persons have rare PVCs? So most of you have had them. And you sometimes you'll feel it if you're really sleep deprived, or you're hypercaffeinated because you've been on call last night and you're trying to stay awake, or sometimes you might have done a really big, extended exercise session and you just kind of feel almost like a bit of a thump in your chest. Well, that thump is the beat after the PVC, because the PVC came early. It emptied the little bit of blood that was in your heart, but now, because there's less blood came out, the heart fills up extra big, and then the next beat after the PVC is extra big. And you sometimes feel that as kind of a little bit of a thump in your chest. If there's a lot of PVCs, or they're really frequent, we sometimes will treat them, try to reduce them with beta blockers or non-dihydropyridine calcium channel blockers. But most people it's just situational, and you just need to, get better sleep, cut back on your caffeine or whatever. Okay, question 24. A 26-year-old male complains of occasional palpitations. He runs 18 miles a week, no symptoms. He drinks 8 cups of coffee and a 24-ounce energy drink daily. So here is this ECG strip you do in the office. So what would you like to do for this guy now? Do you want to put an ICD in, reassure and cut back on the caffeine, amio him, or let's just blast him in the office right now? Let's defibrillate him. Okay, so yes, a common stimulator of PVCs is caffeine. So he's taken too much, definitely too much, so we want to reassure and cut back. Amiodarone, no. Again, as I mentioned before, PVCs, simple unifocal PVCs are very common. This guy has no cardiopulmonary disease. Anyone that is running 18 miles a week like that and is not having any symptoms when he's running, they don't have cardiopulmonary disease. Now, non-sustained ventricular tachycardia is shown here. The simplest definition, 3 or more sequential PVCs at a rate more than 100 beats per minute. So if you saw this on someone who was having an exercise test, this is when we would stop the exercise test. So this is what we call non-sustained ventricular tachycardia, as opposed to this one, which is sustained ventricular tachycardia. And hopefully you can see those PVCs, they're going through, and the arrows I'm showing you there are the atrial beats here. So they're the P waves. You can see the P waves and the QRS complexes are not talking to each other at all. They're not communicating. Just like Chris and Gwyneth. They're just doing their own thing and are, they're happy, but they're not communicating, just like these atria and the ventricles. So ventricular tachycardia is important to diagnose. Most wide complex tachycardias that you're going to see, if you just guess that they're ventricular tachycardia, you're going to be right most of the time. The wider and the nastier they look, the more likely it's going to be VT. If you see one of these, this is called a capture or a Dreslow's beat. So remember here, the ventricles are just depolarizing everything. The PVCs, they've got something going on in the ventricles. So every time the P wave, fires and goes down to the AV node is refractory. But if you get a perfectly timed P wave coming down, hitting the AV node at a perfect timing, when the ventricle, for that few milliseconds where it's actually not refractory, it can go down and cause a normal beat. And this is what's called a capture or Dreslow's beat, and this seals the deal. Managing VT, you want to, if they're unstable, obviously, like any unstable arrhythmia, cardiovert them. If they're stable, see if you can find out what's driving the VT and then amio them or metoprolol if you are thinking of RVOT, ventricular tachycardia. Ventricular fibrillation. So this is chaos. So as opposed to, atrial fibrillation. So in the case of atrial fibrillation, remember we said there were lots of those little circuits going around. The atria are doing this, but the ventricles, so the human ECG, atria, hands, and ventricles are my legs. So the atria are doing this, and then the ventricles are still contracting and pushing out most of that blood, okay? Despite what the atria are doing. So, most people are going to be okay. But in ventricular fibrillation, in this case, you've got the ventricles going like this. And, I'm sorry, Taylor, but they cannot shake it off. And you are not going to be able to shake it off, and you are going to go down. Because if there's not enough blood coming out of those ventricles because they're shaken, then not enough perfusion to the brain, it's time, crash, burn. No discernible P waves, you can see here, and it's sort of like something from outer space there. Let's now talk about pacemakers and when someone needs a pacemaker. Here are the permanent pacing indications, updated. Symptomatic bradycardia. Now, this also includes if someone requires a medicine for their therapy and it is causing them to be bradycardic, that is also, and you can't stop it because they really need it, that is also indicated. Sinus node dysfunction, sinus pauses, chronotropic incompetence. So if you want to define that subjectively, that is, you get them on a treadmill, and if they can't get to 80% of their maximum predicted heart rate. So that's essentially most symptomatic bradycardia or symptomatic second or third degree heart block or symptomatic AFib need a pacemaker. Or someone with syncope with certain findings on a EP study. Now the asymptomatic patients, if they're asymptomatic but they have a significant advanced second degree or third degree AV block, or they have this baby down the bottom here, which is called an asymptomatic alternating bifascicular bundle branch block. So here you've got, this is lead V1, left bundle branch block. Right bundle, right bundle, right bundle, left bundle. This person is a very short time away from going into complete heart block. And this is also indicated even if they're asymptomatic. Okay, syncope. Let's talk about syncope. And, just wanted to talk about, it's kind of funny, the comparison syncope, back in the day. So back, let's say around the turn of the century, you're at at a formal party, everyone's sipping French champagne or wine, and, you feel like, you're going to pass out. And, of course, how embarrassing, for a gentleman or a woman to pass out, in front of company. So, you feel like, gee, I think I'm going to pass out. I better scoot away from the party and go to one of the rooms outside. And so, okay, all right, I'm okay. All right, get back. I don't know what caused that, but okay, I'm feeling better now. Okay. So that was back in the day, but these days, now with syncope, it's like, okay, dude, let's have some more Jägermeister shots. Okay, where are we? Dude, I'm going to pass out quick. Shh. Okay. And then it's like, oh, wow, look how many likes I got. Oh, I got to do it again. I mentioned that in a little bit of tongue-in-cheek. Believe it or not, we are getting patients sending us videos now of different things, seizures, syncopes and stuff. You may have had that too, but this area of medicine is coming in. It's you will see it in the future. That is medicine via smartphone. It is coming in. We're getting it with ECGs and things as well. But anyway, syncope is changing a bit. But the things that have not changed are what causes syncope right now. Now, syncope, just so we're all on the same page, what is syncope? So it is one of those prehistoric kind of things that your body does. So it's like almost like in your DNA. It's like with babies when you drop them back for 6 months, the Moro reflex. It is a deep down reflex. And so here's what happens with syncope. Your brain normally likes to have a very clearly defined flow and blood pressure of blood in a very, very short window. So it's like goes like this. If it goes like down a bit, then the brain kind of releases a little bit more adrenaline from and it really tightens up your vascular tone a little bit, so it goes back up. If it goes too high, it vasodilates a little bit. So it likes to have this, it auto-regulates very, very tightly. So if the brain does that, and let's say the blood pressure falls all of a sudden, and it's going like this, and the brain does this little auto-regulation, and nothing, it doesn't work. The brain's like, okay, it's DEFCON 6. And literally, the brain knows the only way to improve flow is to get you horizontal. So it basically shuts down, it gets you horizontal. It does everything it gets. So true syncope is you are doing something one moment, and the next minute you are on the floor. And complete blackout, you don't know what happened. You don't even know how you got there. That is true syncope. It's not like, I'm feeling a bit dizzy. I might just lay down. I mean, true syncope, that's what it is. It is, I kind of liken it to a Control-Alt-Delete reset, complete reset by your brain of your body, and you are horizontal. Because the brain knows if it takes gravity out, it will automatically improve your blood flow to the brain. It typically happens at a systolic blood pressure of less than or equal to 60 millimeters of mercury. As I said, it's rapid, and then once you're down the ground, the next thing you know, someone's like, are you okay, shaking your hand or pouring water on you, and you're completely awake. You don't have any of the other stuff like you have, for example, with seizures and things like that. So that is true syncope. So there are a couple of types of syncope. The first one is the neurocardiogenic or reflex or neurally mediated vasovagal vasodepressor. That's actually the most common cause. And the common thing is people will actually feel like things are starting to just feel funny, or they may have tunnel vision, and then all of a sudden they syncope. Sometimes it might be something that they do. It might be, for example, when they're urinating, or it might be when a man who is backing out the car and turning around. He's got a tight tie and it's stimulating his carotid sinus. There are certain things. The main thing is you want to, if you can identify a trigger, avoid it. And there are a couple of other things you can do. But most of the time you can identify an issue with the person and try to fix that. Sometimes you might determine that the person actually has orthostatic or postural hypertension. This is the 3-2-1 rule. So within 3 minutes, their systolic blood pressure drops 20 millimeters or more, diastolic 10 millimeters or more, and that is the definition, or the systolic drops under 90. And the main thing for this is that they can't vasoconstrict as well, and they increase their heart rate, and it just makes them feel really bad. Interestingly, the guidelines actually talk about these postural maneuvers or what are called countermeasure maneuvers, and most of them are designed around the fact that the legs actually contain a lot of blood in the venous system. And if you do something to kind of push on the legs or cross them or kneel down, that will actually help bring more blood, increase your preload, and reduce your symptoms. And you can see here, these are quite effective. You can see the blood pressure is graphed when they do the maneuvers, so they're quite effective. The most important thing is, if it's something you've defined, like someone just started a new diuretic on them that caused it, obviously make changes, make sure they're well hydrated, and that they have appropriate salt, and teach them the countermeasures, or think about compression, 20 to 30 millimeter compression socks or stockings. They can be helpful too. And then finally, cardiac or cardiogenic syncope. This is directly related to some cardiac abnormality. It might be Brady, it might be tachy, it might be valvular disease, and you want to work that up and send them to a specialist if needed. Hypertrophic cardiomyopathy. Well, this is one cause of syncope as well. And in hypertrophic cardiomyopathy, you have this really, really fat, thick, particularly septal part of the heart. This is the septum. This is the left ventricle. This is the posterior wall. You can see that juicy fat septum there. And because their septum is big and juicy, they have big R waves often on their ECG in those septal leads. So we treat hypertrophic cardiomyopathy with non-vasodilating beta blockers or calcium channel blockers. Remember, vasodilators will worsen the obstruction, so you want to make sure you don't use vasodilators on your hypertrophic cardiomyopathy patients. If they are still symptomatic despite all of your medicines, then we can consider, and if you find that they have a very high gradient across the obstruction, we can consider sending them for a procedure, either a septal infarction where they literally put alcohol, 100% pure alcohol, in through a catheter and actually cause a infarct in that thick septum so it gets thinner, or they actually go in there and, like a fillet of fish, go in and slice off a big chunk of that septum to reduce the gradient. Now, if you probably remember from your histology classes back in medical school, hypertrophic cardiomyopathy, remember all of the myocytes, it's myocyte disarray. So the whole heart is just completely funky. So by just doing a little stuff on the septum, you don't do anything to the risk of sudden cardiac death. So they still have the risk of sudden cardiac death. And so who should go for an ICD? Anyone with hypertrophic cardiomyopathy who's had a prior cardiac arrest, anyone who's had ventricular fibrillation, and or anyone who's had syncope from or hemodynamically significant ventricular tachycardia. Class 1 indications all should get ICDs. There are some relative indications as well. Remember that autosomal dominant is the most common inheritance for hypertrophic cardiomyopathy. So if you've identified one member of the family, you better get the others in and check their ECGs and or echo, because it's likely 50% chance that someone else has it as well. Okay, holy heart failure, Batman. As opposed to heart success, which the Guardians of the Medical Galaxy, aka you guys, are going to have in your board exam. Heart failure is a little bit of a changing, more with kind of nomenclature. We now say heart failure reduced EF if your heart ejection fraction is less than or equal to 40%, as opposed to heart failure preserved ejection fraction if the heart failure EF is greater than or equal to 50%. And oftentimes this is related to, we call it diastolic heart failure, and oftentimes it's related to hypertension. So we want to do the transthoracic echo originally up front to find out what type of heart failure they have and if there are any things that we can fix to help it. We can use BNP acutely in the emergency room. If it's really low, it's going to be, their dyspnea is probably from their COPD. So the stages, someone was asking before, and stage A in the new classification, if you've got someone who has hypertension, so that patient you're seeing in clinic with hypertension, they are now classified as stage A heart failure, or a diabetic. And basically that means they are at high risk for developing heart failure in the future. And so I've got a little mnemonics here to help you remember what to do at the different stages. So with stage A heart failure, A for ACE inhibitor ARBs, especially if they have hypertension, and A for atorvastatin, if statins are indicated. So that's stage A. So stage B heart failure, this is when you do an echo and they actually do have something abnormal. It might be they have LVH, really thick walls, or they may have a reduced ejection fraction, but they're actually feeling okay. They say, I'm feeling okay. And so for that, stage B, B for beta blockers, B for bypass, and B for BUSM. So if they have an EF less than or equal to 35%, you should refer them for an ICD. Stage C heart failure is symptoms. So in this case, they have dyspnea, fatigue, decreased exercise tolerance. So stage C for symptoms and C for curtail their edema with loop diuretics, combo hydryl isosorbate dinitrate, and C for CRT, cardiac resynchronization therapy, in the appropriate candidate. And we'll go over that in a moment. And then finally, D, stage D is rest symptoms or frequent hospitalizations. These are your frequent flyers. And D, I think of D as deliverance. Either they get delivered a new heart if they're lucky enough and a transplant, or D for DNR, and they're delivered to the intensive care unit in the sky. So D also for donor heart, dobutamine, drugs, devices, DNR, palliative care, and deactivation of the high ICD. And I've got the indications, contraindications, for transplant down the bottom. So your diabetic who has end-stage end organ complications pretty much is not a candidate for that, or if they're older. Question 25. A 59-year-old Hispanic male patient has a large anterior STEMI 1 year ago. Ejection fraction 15%, had cabbage. He is retired, paints, and does other activities of daily living. He's on good medicines, including carvedilol, sacubitril, valsartan, aspirin, clopidogrel, furosemide, eplerenone, and atorvastatin. His physical exam, he's good. Blood pressure is pretty good. He's got an S3, you hear. He has less than 1 mm of pedal edema, so pretty compensated. His ECG shows the old anterolateral. Now, a month ago, you repeated his echo, and it shows his ejection fraction is 29%. He's got anterolateral hypokinesis and moderately dilated left ventricle. So hopefully you've determined what stage of heart failure he is in now, and that will help you to manage him. So what would you like to do? Just continue what you're doing and get an echo in a year. Switch beta blocker to metoprolol tartrate, refer for ICD, refer for transplant, or add candesartan. Okay, let's see how everyone's feeling about this one. Okay, good. Most of you got were on the money. So refer for ICD. So he has heart failure, and he's got an ejection fraction less than or equal to 35. Remember I said before, anyone with heart failure with ejection fraction less than or equal to 35 should be referred for ICD. B is wrong. Switch beta blocker to metoprolol tartrate. Remember, metoprolol succinate is the only one indicated. Tartrate is bad. You don't want to use that. You don't want to continue this because, again, he could have a sudden cardiac arrest and die because you didn't have an ICD in. Because we know people with an EF less than or equal to 35% are at much higher risk. No, we don't refer him for transplant. He's doing his ADLs. He's, has got hobbies and he's doing all of that. So we would not, he is not a transplant candidate at this time. Okay, I will survive on ACEs, ARBs, ARNIs, aldosterone antagonists, beta blockers, and hydrolyl nitrates. So these, guys and girls, are the medicines that will improve survival in heart failure. So we like them. So ACE inhibitors and ARBs. Now a new change is this ARNI here. And I'm not talking about the Schwarzenegger ARNI, I'm talking about the angiotensin receptor neprilysin inhibitor, sacubitril, valsartan, Entresto. So the latest update on the guidelines say we replace your ACE and ARB with the ARNI. If you've got symptomatic heart failure reduced EF, patients with an NYHA 2 to 3. So it's better. It was put up in the Paradigm heart failure trial. It was superior to an ACE inhibitor, enalapril, significant reductions in death and heart failure. So now it is indicated first line as the treatment of choice, heart failure reduced EF with New York Heart Association 2 to 3. So how do you do it? I mean, because I'm sure you, like me, have lots of patients in our clinic who are on ACEs and ARBs. So what you do with the ACE, you stop it for 36 hours. So basically, I'll say, stop it, hold your ACE today and tomorrow, and then start the sacubitril the next day. With ARBs, if they're on an ARB, you don't have to have the delay. You just tell them, stop the ARB, you only have to wait 12 hours, and then start the sacubitril the next day. Aldosterone antagonists, we talked about that. Beta blockers. Now, importantly, with beta blockers, you want to get them to goal. So you need to, when you start beta blockers on these individuals, you want to up-titrate every 2 to 4 weeks, so you want to see them back at least monthly and increase the dose. You want to get them, so for example, carvedilol, you want to get them to 25 BID. And you keep going until you get the heart rate of 60 or lower, or they actually have symptomatic hypertension. Remember, these drugs had the best results at the very highest doses. Now, medicines are also used for symptom control, but these don't actually improve survival, including loop diuretics, aquaretics, digoxin, sinus node IF channel inhibitors, modulators, positive inotropes, IV vasodilators, and importantly, for your patients with heart failure, these medicines in particular can lead to exacerbations. So the thiazolidinediones, so glitazones, most calcium channel blockers, except amlodipine and felodipine. So you don't want your heart failure patients on them. NSAIDs and cyclooxygenase 2 inhibitors have all been shown to worsen heart failure. Cardiac resynchronization therapy, I talked about that before. This is essentially also known as biventricular pacing. So the three things they have to have if you want to send them for biventricular pacing. Number one, ejection fraction less than or equal to 35%. Number two, sinus rhythm with a left bundle branch block and a QRS duration greater than or equal to 150 milliseconds. And finally, NYH 2, 3, or ambulatory with 4 symptoms. Those people have been shown to have significant benefit from the biventricular pacing. And the reason is, with that really severe left bundle branch block, what's actually happening is they're, instead of nice synchronized with both ventricles contracting together, what's happening is you're getting the right ventricle contracting, and then later the left ventricle's contracting, and you're not getting this nice synchronized, and it actually interferes a lot with blood flow. If you're seeing someone for the first time in your clinic with heart failure and they have all of those criteria, you in fact should refer them for what we call CRT-D. So this is a biventricular pacer or cardiac resynchronization therapy with a defibrillator. So this has the whole picture. And this is a great device, and that will take care of everything if they meet those criteria and have no device in so far. Let's now talk about acute pericarditis. This is a common cause, particularly in younger people, that you see in the emergency room. Might be that they're on hemodialysis and they're getting it, or might be that they had a viral infection. And you can have subtle changes, ST changes here. You can see it. Oftentimes it's throughout that whole ECG. Commonest cause that we see are viral or bacterial, autoimmune, uremic, lymphoma, Dressler's, medicines. Remember, minoxidil is a common cause. And these are the individuals, again, they also will come, they'll do the Rodin. You'll see them in the hospital bed and they'll always be leaning forward because they get relief. Just like our lumbar spinal stenosis patients, remember? They will get relief from flexing the spine forward. If you're lucky enough, you might hear this 3-component rub. And sometimes they may have an associated myocarditis, so they may actually have a little bit of a positive troponin. But most of the time, you don't have to do anything specifically for that. Importantly, until they've fully recovered, no strenuous exercise. So that's only one of the few times that Dr. Starlord will tell patients not to exercise. If they have acute pericarditis, if they have a fever over 39, or if they just ran a marathon yesterday, I give my residents the day off from exercising. Okay, here's the stages on the ECG. Here's the classic stages. So stage 1, you've got this concave up, big ST elevation. You've got the PR depression, which you can see here, except in AVR where it's elevated. And then stage 2, they come down, T waves invert, and then the ECG is normal. And treating this, we hit them pretty hard with the aspirin and then NSAIDs. If they are still having symptoms despite that, or they have a recurrence, that's when we think about colchicine. If they also are post-MI, we avoid NSAIDs because remember, NSAIDs are going to interfere with the recovery of the heart. We typically, in that case, will do just aspirin, and then we will add colchicine if needed. Oh, and importantly, do not use steroids. Sometimes the boards will get you, and sometimes you'll have patients, that someone started on steroids and they're feeling great. Well, anyone you start on steroids feels great, but anytime you try to cut them back, they get recurrence. So do not use steroids. Constrictive pericarditis. So this is skull heart. I think you remember this ECG from this chest x-ray from lecture 1. And you can see here, this was a 37-year-old female in the Philippines with a history of a positive PPD. So she had tuberculous constrictive pericarditis. However, in the United States, most commonly, it's either that idiopathic or viral, or they had cardiac surgery. Little radiation TB and cancer. So someone with lymphoma, particularly if they've had radiation, they are set up for constrictive pericarditis. They typically present with right-sided heart failure signs, and one of the tip-offs is the pericardial knock. So remember, systole starts with S1, diastole starts with S2. So after S2, you sometimes hear this knock, almost like a thud, and this can be a tip-off that this is constrictive pericarditis. You can check them out with the echo and or the other imaging and see 4 millimeter thick pericardium. If they do have NYHA 2 to 3, we like to strip them. And I'm not talking about taking their clothes off, but I'm talking about removing the pericardium. But do remember that the mortality is about 1 in 10. It's not a low-risk procedure, so you only want to do it if absolutely indicated. A 64-year-old man with a history of lymphoma, status post-chemo and radiation, has been to the ED several times complaining of dyspnea, general fatigue and peripheral edema. Nebulizers do not help. You note elevated neck veins that increase on inspiration and a diastolic knocking sound at the left sternal border, ascites and pedal edema. So what is the likely diagnosis in this man? Pulmonary emboli, ASD, exacerbation of COPD or constrictive pericarditis. And I've got a good feeling that you guys are going to nail this. Hey, 100%, I love it. Good job, guys. So yes, he had the classic. He's got the diastolic knock, lymphoma, radiation, all of that goes nicely, and the right-sided heart failure signs. Good job, second 100%. Let's now talk briefly about restrictive cardiomyopathy, or what I like to call filet mignon heart, because it's a nice, thickened heart with thick myocardium and diastolic dysfunction, dilated atria, and amyloid is actually the most common cause of restrictive cardiomyopathy or filet mignon heart. So they're really, really thick. They have diastolic dysfunction. There's a bunch of different etiologies of this, everything from hypertrophy, for example, with someone with really severe hypertension, to infiltrative, to storage, to inflammatory, idiopathic. Again, they have very similar presentation to constrictive pericarditis. So that's why it's so important to get your echo to help differentiate between those two. So pericardial effusion, finally, pericardial effusion can be normal, is less than 5 millimeters, less than 100, moderate or severe. And etiology for them, most of the time, honestly, we don't even find out. Most of the pericardial effusions that I see, it's, viral. We check an echo a few months later and it's gone. And they're not hemodynamically compromised. But you do see them, of course, in uremia, as well as neoplasms. And the common neoplasms that cause pericardial effusion are LMNOOP, lung leukemia, melanoma, non-Hodgkin's lymphoma, OO for breast, and pericardial effusion. So those are the commonest causes of cancer causes of pericardial effusion. So the main thing is, do your usual workup. If they're not hemodynamically impaired, we normally just send them home and repeat it. If it's still there or it's gotten worse, in 3 months we then tap them. Cardiac tamponade, of course, is a pericardial effusion under pressure. And this is normally, they're very symptomatic. We'll have the pulsus paradoxus, and we can see these changes on echo. And typically, if they are hemodynamically impaired, we need to tap this. Importantly, if their systolic blood pressure is under 100, then what you want to do in the ED, get them volume, because they are really, really preload dependent. And so you want to increase that and then organize for a pericardial drain. Let's get on to lecture 5 of the marathon, the last lecture. We're going to be talking about congenital heart disease, a little bit of pulmonary heart disease, pregnancy in the heart, and a little bit of ECGs, and just some final thoughts from myself. So let's talk about congenital heart disease. Drop it, Sean White. So D, defect, VSD. R, right ventricular hypertrophy. O, overriding aorta. P for pulmonary stenosis, which is T, tetralogy of Fallot. And Sean White, the flying tomato, who I believe got 2 golds in Sochi just recently, was born with tetralogy of Fallot. And so his heart would have looked like this. This is the classic boot-shaped heart. And the reason I show you this to you is that we are getting better and better at diagnosing. Many of these conditions, in fact, are diagnosed in utero before the baby is born, and planning for procedures is going on before the baby is even born. So we're getting better at detecting them, at fixing them, and people can live long and healthy lives, and even exceptional lives, like in the case of Sean White here. So you will be seeing more and more congenital heart. So I just wanted to go over some of the common things that come up with congenital heart, and also the boards will maybe ask you about. Patent foramen ovale, PFO. Very common, 30% of the population, which means that there are people sitting down here who have a PFO. And most of the times, you're asymptomatic and we don't do anything. We consider closing it if, despite having you on platelets or some other antiplatelet therapy, you have a cryptogenic, what we call cryptogenic stroke. That is, we can't find an origin and you happen to have a PFO. And we diagnose it most commonly with an echo bubble study. Here's the right side of the heart, here's the left side of the heart. Normally, bubbles, when we inject bubbles through the arm, they go to the right side of the heart, then they have to go all the way to the lungs for a few beats, and then they come back to the left side of the heart. But if you have a PFO connecting the atria, or an ASD for that matter, the bubbles go immediately across to the other side, and that's how we diagnose it. But most of the time, this is incidentaloma, and we don't do anything. Patent ductus arteriosus, or PDA, this is the classic machinery-type murmur. Here we have a connection. This is our, the original connection when you are still inside your mom between the aorta and the pulmonary artery. It's supposed to close, but sometimes it doesn't. We do close it if someone is symptomatic, if they have a left heart enlargement, or they have left to right shunting. And pretty much that means most of them we close. Pulmonary valve stenosis. So a small portion of individuals are born with this. It's congenital, and they often will have right ventricular hypertrophy. That's how often they're picked up, or the murmur, of course. There is a particular condition called Noonan syndrome, and my little mnemonic for that is PEN. So pulmonary stenosis, and the E for ears that are low set equals Noonan syndrome. So here's a little girl with Noonan syndrome who has pulmonary stenosis. When to close these? If they have symptoms, if they have right ventricular dysfunction, if they have a mean pulmonary valve gradient of greater than or equal to 30 millimeters, or a peak of greater than or equal to 50, then we should fix them, and these can be fixed really well with balloon valvuloplasty. If they've got other abnormalities present and more complex valve abnormalities like dysplasia, we generally have to do a pulmonary valve replacement. VSD, ventricular septal defect, aka very small dudes and dudettes, because this is the most common congenital heart disease in children. The good news is most of them are membranous. So I've got a picture here. You can see the different types. The membranous one is the commonest. It's kind of just sitting smack here in the middle. And the other good news is that most of the time, as the heart grows and the child grows larger, these actually get closed over by different by other parts of the membrane, and they disappear. They will, have our harsh systolic murmur. When to fix these? If they have a shunt greater than 2, that means a really large shunt, left heart enlargement, pulmonary hypertension. If they have this particular type here, this is called an infundibular or supracrystal VSD. It's right next to the valve leaflets of the aortic valve, and what happens is, because of a Venturi effect, the valve leaflets kind of get sucked into it, and it makes severe aortic regurgitation. And then finally, if they have endocarditis. Now, cyanotic heart disease, you should go through the differential diagnosis when you get a cyanosis case. Most of the time, it's going to be one of these. So the 5 fingers, actually, we start with 0 for pulmonary atresia, 1 for truncus arteriosus, that's one big trunk vessel coming out of the heart, 2 for transposition of the great arteries, so DTGA, 3 is for tricuspid atresia, 4 is for tetralogy of Fallot, and 5 is for total anomalous pulmonary venous return. There are 5 words in that condition. A couple of things to note with people that have cyanotic heart disease: you want to avoid vasodilators. They will worsen their cyanosis. Also, iron deficiency anemia is very common, and so sometimes we use short-term iron therapy to help improve exercise capacity and quality of life. And very, very importantly, if they have any type of neurological symptoms and they come in with a sepsis-type picture, you should assume they have a cerebral abscess. Admit them, get them scanned and everything, because this can be life-threatening. Anomalous coronary artery. So A for not, nomo, or normal. So this is not a normal located coronary artery. So here's the front of the person over here, and here's the back of the person. Here's the pulmonary trunk here, pulmonary artery, and here's the aorta. So the first one that is really problematic is when the left main coronary artery comes off the right coronary artery and then goes between these vessels, and you have divides into the circumflex and the left anterior descending. And then the other type, which is problematic, is where the right coronary artery comes off the left and runs between these vessels. So what happens is, when you're just at rest here, your cardiac output is about 4,900 cc's. So, at rest, your heart is beating at about 70 beats per minute, and your stroke ejection volume is about 70 cc's per beat. So 7 sevens, 4,900. When you exercise, what happens to that cardiac output? It goes way up. I mean, depending on what type of exercise and how fit you are, it might double, it might triple, it might quadruple, but that goes up. So there's going to be a lot more blood being pumped out of these two vessels, and so these vessels actually distend a bit and essentially squish those anomalous coronary arteries running between them, and that is a problem. And that can cause chest pain because they can get ischemia. It can even lead to them having ventricular tachycardic arrest. We diagnose this by imaging. So when to do surgery? If you've got a situation here, the left main, because remember the left main is supplying the majority of the heart, if you've got this situation here, that has to be repaired immediately. And then if you've got any other situation like this or any other situation, if they have symptoms, then they should be corrected. Okay, so let's take a look at our first question of the afternoon. Which of the following patients should be referred for surgery? Coarctation of the aorta with heart failure, VSD with pulmonary hypertension, anomalous left main coronary artery running between the aorta and pulmonary artery, an ASD with a 2-to-1, greater than 2-to-1 left to right shunt, or all of the above. All right, so yes, most of you got it. All of those are indications, not just C and D, but also the A and B are also, these are clear class 1 indications for surgery. So most of you are on the money there. Very good. Okay, while we're on that topic, let's talk about sudden cardiac death in young athletes. And this is normally defined as an arrest within 1 hour of the onset of symptoms. So with this, there are 4 main groups of conditions that are associated with sudden cardiac death in athletes. The first are the cardiomyopathies, including hypertrophic cardiomyopathy, which is felt to be the most commonest one in the United States, arrhythmogenic right ventricular cardiomyopathy, and then myocarditis or dilated cardiomyopathy. The second main group are the congenital coronary artery anomalies, which we were just talking about, which is thought to be the second most common in the United States. And then the electrical disorders and channelopathies, which include long and short QT syndrome, Brugada syndrome, Wolff-Parkinson-White, and catecholaminergic polymorphic ventricular tachycardia, as well as commotio cordis, or mechanical electrical syndrome. And there's a picture of someone with that ECG of someone with catecholaminergic polymorphic ventricular tachycardia. And then finally are the valvular and aortic disorders, including bicuspid aortic valve, aortic rupture, Marfan syndrome, coarctation of the aorta, and pulmonary stenosis. Now, importantly, most of these are also AD, autosomal dominant. So if you do identify someone with one of these conditions, be sure to check out other family members who also may have these conditions, and you can, potentially save another life. So let's see how short-term memory is on you guys and girls this afternoon. Conditions associated with sudden cardiac death in exercising young people include hypertrophic cardiomyopathy, congenital coronary artery anomalies, long QT syndrome, Brugada syndrome, all of the above. I have a 100% feeling coming on here that my guardians of the medical galaxy are going to deliver. Okay, you 98% legends. And yes, Brugada is, and yes, congenital coronary arteries, but yes, long QT and hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy, remember, is the commonest cause of sudden cardiac death in exercising young people in the United States. Pulmonary heart disease. Let's talk about some of the conditions on the right side of the heart that kind of affect the heart. So the first big one is cor pulmonale. And what this is where you have an abnormal right heart, right ventricle, because of lung problems, the commonest being COPD. And they often have a chronically slow progressive course with acute exacerbations. Eisenmenger syndrome. So the setup for Eisenmenger syndrome is you have a large, unrepaired left to right shunt. So we're talking here about VSD. It's high pressure and high flow. VSD is actually the commonest cause. Atrioventricular septal defect, where you have an atria and a ventricular septal defect together, for example, with your trisomy 21, and PDA, patent ductus arteriosus. So what happens is, over time, you've got all of that high flow and pressure going from the left to the right. The right side starts getting thicker, stronger, blood vessels, muscle, to the point where it actually, the pressures equalize, and then the right gets even more stronger, and it starts shunting blood from the right to the left. So now the blood's going the other way, and it's not going through the lungs, so they're going to be cyanotic. Again, iron deficiency anemia is very common with these people, so they may need short-term iron. And VSD, as I mentioned, is the commonest cause of Eisenmenger syndrome. Here is a lady who had an atrioventricular septal defect, and you can see she's got central cyanosis, clubbing there, as well as a peripheral cyanosis. And unfortunately, the vessels and the right side of the heart are irreversibly affected by this condition. And so the only way to really cure these people long-term is a full heart-lung transplant, which is not easy due to resources. Okay, let's now discuss pulmonary hypertension, who they generally will present with dyspnea on exertion, and the cath definition is a resting mean pulmonary artery pressure of greater than or equal to 25 millimeters of mercury. So the classification of pulmonary hypertension. Number one, this is the WHO. Number one, pulmonary arterial hypertension. Number two is pulmonary hypertension from left heart disease. Number three is pulmonary hypertension from lung diseases. Number four is chronic thromboembolic pulmonary hypertension, and number five is pulmonary hypertension with unclear or multiple mechanisms. And this is the WHO classification of pulmonary hypertension. We often use oxygen to maintain their saturation over 90%, and importantly, when they get those right-sided heart failure signs, loop diuretics and spironolactone are really, really good to help treat their symptoms. I'd like to focus on the group 1, pulmonary arterial hypertension. So this is either drug-induced, heritable, or idiopathic. It's most common in young women and is refractory, really refractory in most cases, and they die generally within 10 years. Now, we do this vasodilator treatment on them to see if they respond. If they do react to a vasodilator, which is defined there, they seem to do very well for a longer period of time on calcium channel blockers, like nifed, DILT, and amlodipine. If they're unreactive, so they don't react, and the board asks you, what should the patient be taking? The answer, per the most recent AMBITION trial, clearly is ambrisentan plus tadalafil, that combination, AT, if they're unreactive. There are other medicines that are used in other specific situations, and importantly, all of these people should get Coumadin because they are at very high risk of in situ thrombosis. And the heart-lung transplant, again, in these individuals is the only way we can really potentially cure them. Okay, how about pregnancy in the heart and some of the things you need to know for your women who are either planning on or are pregnant with who have heart conditions. So remember, pregnancy is all about flow. It's reduced vascular resistance. There's a lot of flow because it's going from the mom to the baby. So obstructive lesions, they interfere with flow the most. They are poorly tolerated. Whereas regurgitant lesions, because of the reduced afterload and vasodilatation, actually often get better. The long QT mom, if you've got a beta blocker on board, you want to continue it, that's okay. And mitral stenosis. So a woman with mitral stenosis, they will often present a lot worse later in the pregnancy. So at about 32 weeks is when your cardiac output and your volume peak. And that's when you want to try to help them symptomatically. You can try beta blockers, metoprolol and acebutolol in particular. They do not suppress uterine contraction. If they get really, really severe, which I've seen a couple of cases of, sometimes they actually have to do the valvuloplasty on the pregnant woman and baby. Peripartum cardiomyopathy. This is a cardiomyopathy that develops either in the last month or in the first 5 months of pregnancy. It has a mortality up to 1 in 4, so it's a very serious condition. There are certain risk factors, for example, African ethnicity and multiparity. This is the rule of halves. So a half will improve the left ventricular ejection fraction in about 6 months' time, and a half stay the same or get worse. And because of the high risk of recurrence, we generally recommend that they do not have any future pregnancy. And then finally, the one you see, this is the young, healthy woman in the 3rd trimester or just after delivery who has a STEMI. And basically what's happened is they dissect their coronary artery. Remember we talked about the 3rd trimester of pregnancy as being an independent risk factor for thoracic aortic aneurysm because it affects the muscle of the wall, the hormones somehow affect it. Well, it also affects that in the coronary arteries, and they can actually dissect. And here is what's called OCT, or optical coherence tomography, inside the coronary artery, showing here's the device itself, here's the coronary artery wall, and hopefully you can see this flap here, and there's the dissection here. This is the dissection that occurred in this pregnant woman here. And we basically treat them as we would with anything. I mean, they go to the cath lab and they get stented, bypassed in some cases. And importantly, there is an association with abnormalities of the brain, dysplasia and other arterial abnormalities, as well as fibromuscular dysplasia of the kidneys. So you want to check for those afterwards, after everything's all settled down. So what are the absolute contraindications to pregnancy? This means that there's a 50% chance that the mom, or greater, that the mom is going to die. So pulmonary arterial hypertension, or Eisenmenger syndrome, LV ejection fraction less than 30% with NYHA 3 or 4, peripartum cardiomyopathy with LV dysfunction, severe mitral or aortic stenosis, Marfan syndrome if they have an aorta of 45 millimeters, greater than 45 millimeters, or bicuspid with an aorta over 50. Those need to get fixed first. And then finally, native severe coarctation. They are the absolute contraindications to pregnancy. So the good news is there's a lot of cardiac medicines that are okay, but there is a bunch that are bad. So the ones that are bad, Coumadin or warfarin over 5 milligrams daily, contraindicated. So if, let's say you have a woman who has a St. Jude mitral valve and they're pregnant and they're on Coumadin 10 milligrams daily. Then what we do with that situation is what we call a heparin sandwich. So we do heparin at the start for weeks 1 to 12. Then we would switch them back to their Coumadin for 12 to 36. Then we would switch them back to heparin. Kind of like the heparin's the bun and the Coumadin is the meat in the sandwich. The good news is if they're only taking 5 milligrams or less Coumadin, you can continue that all the way through until 30 weeks, 36 weeks, and then switch them over to heparin. Aspirin in the 1st and 3rd trimesters, statins, ezetimibe, amio, dronedarone, bosentan, ACEs, ARBs, thiazide, spironolactone, aliskiren, which is a direct renin inhibitor, those are all contraindicated. The good news is, as I mentioned, Coumadin 5 milligrams or less, heparin, low molecular weight heparin, aspirin, actually 81 milligrams per day in weeks 12 to 28 is now indicated as a preeclampsia prevention for certain individuals. DIG, quinidine, procainamide, acebutolol, metoprolol, propranolol, labetalol, and alpha-methyl-dopa. Remember, those are actually our drugs of choice for treating high blood pressure in pregnant women. Verapamil, diltiazem, nifedipine, vagal maneuvers, adenosine, and synchronized cardioversion. So there's a lot of our common medicines that we can use in our pregnant women. Okay, now let's move on briefly to the 12-lead ECG and just go over some of the ECGs that we haven't done in the rest of the presentation. And hopefully, you guys and girls have all got the good vibrations, which are shown on this ECG. So the bipolar leads, Roman numeral 1, 2, 3, and the limb leads, ABR, ABL, and F, and the precordial leads, V1, 2, 3, 4, 5, 6, with the normal R-wave progression. Yep, I'm picking up good vibrations from the Guardians of the Medical Galaxy. So this is our normal, smack normal ECG. Let's have a look at a couple of abnormalities on the ECG. The premature atrial contractions, the PACs. These are premature, before mature, so they come before the mature beats. They are from the atria. So they arise somewhere from the atria other than the SA node. And so the P wave morphology is going to look a little bit different, and often the PR interval is a bit longer. So here is normal beat, normal beat. Now I've measured the interval between the RR here, just to show you. Here's normal beat. Now here is our PAC coming along. Now you can see this P wave looks a bit different. PR interval is a little bit longer. The QRS complex is the same. Importantly, after a PAC, the next regular beat comes with normal timing. So do you see that? It's not short, not long, it is just right. So this distinguishes this as a PAC. Focal atrial tachycardia is where you have atrial tachycardia. So it's, there's some sort of tachycardia. It's from some focus in the atria. And it's not a flutter that's going all the way around the atria, creating those sawtooths. So you don't see sawtooth. In fact, you often see an isoelectric segment between the P waves, unlike the flutter waves that you see. And if they're unstable, again, any unstable arrhythmia, you cardiovert them. And if they're stable, you just slow them down. The good news is, oftentimes they can find the source of this atrial tachycardia on an EP study, find it and ablate it, and you're done. Supraventricular tachycardia. Let's talk about supraventricular tachycardia. So this is narrow complex tachycardia. The commonest cause is AV nodal reentrant tachycardia. So in this situation, you've got an AV node here, and there's two pathways. Normally, this is just a fast pathway, and here you've got a slow and a fast pathway, and you get this little loop setting up here. The other common cause, so basically you've got a circuit set up, is AV reentrant tachycardia, so going down the normal pathway here in the orthodromic situation, and then coming back up that Wolff-Parkinson-White accessory pathway. And so this starts the tachycardia, and so these are the two common ones. So if you have a narrow complex tachycardia and they tell you that they did a vagal maneuver or IV adenosine and it terminated, it's either this one or this one. These are the two common AV supraventricular tachycardias. And here is what this looks like on an ECG, a 12-lead ECG. Here's AV NRT. I wanted to show you because this is the commonest one. And so just think, if you had AV NRT, when you're trying to play basketball, you're in the Final Four or something, this would slow down your game. So just think of AV NRT would slow down your game. So what happens in the typical AV nodal reentrant tachycardia? The extra beat occurs here, and then it goes down the slow pathway. So it goes down, it takes a really long time to get down and depolarize the ventricles. And then it comes up the fast pathway. So the ventricles depolarize, and then almost immediately after the ventricles are depolarized, the P wave occurs because it's gone up to the atria from the fast pathway, and then it goes down the slow pathway. And what they do to fix this, we can treat it with medicines just symptomatically in the meantime and all that, but what they do is they go in and they actually find both the fast and the slow pathway, and then they use their little zapper or a cooling agent. Often nowadays they freeze, and they just freeze the slow pathway. End of story. And that's it. Very, very successful treating this AV NRT. Most common one in young and middle-aged women, this AV NRT. First degree AV block. So the PR interval is greater than 0.2 seconds. So this is pretty straightforward. It's no big deal. Most of these people don't even know it. They're asymptomatic, and you don't do anything for this. You just kind of are aware of it. Second degree AV block type 1, Wenckebach. This is where you have a dropped QRS complex without progressive prolongation, with progressive prolongation of the PR interval. So in other words, you have P and then the R, and then P, and a slightly longer, and then eventually you get the drop beat here, and you get this what's called grouped beating. Again, almost all of the ones I see of this are asymptomatic. It might be that they might have been on a calcium channel blocker, and then someone started them on a low-dose beta blocker, or vice versa. I've seen that all the time, and so we just kind of stop one of the negative inotropic agents, and oftentimes this goes away. Most of these are asymptomatic, so don't need to be paced. However, second degree AV block type 2 is where you have no progressive prolongation, you just have dropped beats. They're just not going through. This is a lot more ominous. And importantly, when you give atropine, oftentimes because they are given atropine, these people are given atropine in the emergency room, it has no effect on this, or it actually gets worse. And that's a tip-off to tell you this is a second-degree AV block type 2, the no effect or paradoxically worsening with atropine. And most of these people are symptomatic and, dizzy or, feeling like they're going to pass out, or they have passed out, and most of them are going to need a permanent pacemaker. And a third-degree AV block or complete heart block, this is also a situation a little bit like VT, where the atria and the ventricles are not communicating with themselves, but in this case, the atrial rate is going to be greater than the ventricular rate, as opposed to VT, where the ventricular rate is greater than the atrial rate. And I've marked the atria with the blue arrows here, so the P's going off there. And you can see there's just no, P's are just doing their own things, and they don't mind about what the QRS complexes are doing. And these people are generally symptomatic and need a pacemaker. So the QRS complex represents ventricular depolarization. That is, when the ventricles are going off and contracting. And this is, most of this time, this happens very fast, less than 1/10 of a second. If it is increased more than 1/10 of a second, generally that means there's something else going on. The commonest thing that we see with prolongation of the QRS duration are the bundle branch blocks. And there's two bundles, so there's two bundle branch blocks. The right bundle branch block is shown here. So you can see they have the rabbit ears in V1 and V2, and you have the slurred S in leads 1 and AVL and the lateral leads here. You can see that R and the S. This is classic for right bundle branch block compared to the normal there. And left bundle branch block, in this case, the left bundle is no longer working. So everything goes down the right bundle and then goes leftward. So if you imagine you were sitting on V1 over here, you are going to see mainly the vector going away from you. And remember, something going away from a positive force going away from an electrode causes a negative or downward deflection. And so in these anterior leads, you often see these either a little R or no R and just a big Q wave because the vector is going away. And sometimes you will see in the lateral leads, you may see the rabbit ears out here in the lateral leads, but this is left bundle branch block. Ventricular paced rhythm. So I like to call this the man-made left bundle branch block, because essentially what we've done is we put a pacemaker into the right ventricle, and it fires the right ventricle, and then it goes across to the left ventricle, just as kind of what happens with a left bundle branch block. Same thing, except you've got a spike. So here you can see there's a pacer spike, and then kind of what appears to be a left bundle branch block here. QT interval. So the QT interval, normally the QT interval should be less than 50% of the RR interval. So you can see here's a normal QT interval here. You can see it's less than 50%. Here's the QT interval here. It's less than 50% of the RR. Here you can see a longer QT interval here. It's definitely extended, and we've actually, most of the time we are interested in long QTs, but there is now a defined condition of short QT interval that's dangerous. And that was on that list, remember, I showed you before, of things that can cause sudden cardiac death in young athletes. Long QT interval is typically greater than 0.47 seconds. What you have to, I think the main things for you to remember is if you have someone and you start them on a drug and the QTC goes over 500, or it increases 60 milliseconds or more than 15%, it is probably problematic. You should stop that medicine and try to find a substitute. And if you have a long QT syndrome patient, a known patient, you want to avoid QT prolonging medications. And so here is an example of a patient who had long QTC, and you can see there we've measured it, and you can see it is more than, you can't fit 2 of those QTC intervals into the RR interval. And here's my little mnemonic for what are the common medicines or things that will prolong QTC. The PA admits at headquarters. So P for procainamide phenothiazines, A for azoles, for example, ketoconazole, and the admits amiodarone, dofetilide, droperidol, disopyramide, macrolides, for example, erythromycin, common one that we use, ibutylide, tricyclic antidepressants, and sotalol, and then H for haloperidol, hypo, pretty much anything, hypocalcemia, hypomagnesemia, hypopotassiemia, hypothyroidemia, hypothermia, and then quinidine, Q for quinidine, and quinolones like ciprofloxacin are all associated with prolongation. They're the common ones that the boards often like to ask about. So why do we care about this? Because a prolonged or a long QTC can lead to this condition called torsade de pointe, or twisting of the points. And you can see here this polymorphic ventricular tachycardia. You can imagine, Pepe on the Champs-Élysées with his accordion, serenading the Parisian girls as they walk by. So this is like accordion-type motion. Hopefully you can see that accordion-type motion. And we typically will hit them pretty early on with IV magnesium sulfate and or potassium, because that will help, and if needed, we'll pace and do isoproterenol. But oftentimes, these people code as well. It's got a really tricky situation. Left axis deviation. So let's talk about axis for a little while. So normally, here's your heart here. The vector of the heart kind of goes like this, in this plane. So normal axis is kind of from here, positive 90 to negative 30. Left axis deviation is when the vector goes up, way up this way. And the common reasons for the vector to move upward like this is either you've got a lot of muscle on the left side, pulling the vector more leftward, or you've got a damage to the muscle on the right side and the inferior part, causing, again, the mean vector to go more upward that way. So they're the commonest causes of left axis deviation. In contrast, right axis deviation is more common in individuals that have right ventricular hypertrophy and strain, and that can be acute or chronic. So someone, for example, with a pulmonary embolus, an acute pulmonary embolus, can have a right axis deviation, or someone with really bad COPD with right ventricular hypertrophy can also have a rightward axis deviation. Also, if the left ventricle has been damaged and there's not much electricity from the left side pulling the axis there, then the axis will move more rightward. And as we talked about before, the classic ostium secundum ASD, that common ASD that we were talking about, that often has the classic ECG appearance with right axis deviation and right incomplete or complete right bundle branch block. Right atrial enlargement. Remember, the right atrium is sitting right here underneath V1. So again, if you're looking at V1, if I'm looking at it, that energy from the right atrium coming towards me, if the first part of the P wave in V1 is higher than 1.5 millimeters, that is a tip-off that you've got right atrial enlargement. And also if you have a big P wave in leads 2 or 3. Left atrial enlargement, that's going to be, remember, the right atrium goes off first and then the left atrium. So if the downward and the left atrium is going away from V1, so if you look at the latter part of the P wave, if the downward part is more downward than 1 millimeter, then 1 millimeter or more, that is suggestive of left atrial enlargement. And here's an example of that. Left ventricular hypertrophy. So LVH, thick left ventricle. Remember, the LV is over here. It's kind of located under V3 through 6. So if you take, and one on AVL, so if you look at those leads, you're going to have higher R waves in those leads. A great one, which is really specific, that I would recommend you to remember is the Sokolov-Lyon criteria. So R in AVL, if that is greater than or equal to 11 millimeters. So if you think of an L and you sort of turn it around, it becomes a 1. So that may help you to remember the R wave in lead AVL greater than or equal to 11 millimeters is a very good criteria for left ventricular hypertrophy. There are some other criteria as well. So here's a 55-year-old Caucasian with hypertension, and you can see he's got the R in AVL greater than or equal to 11. He's got the Cornell criteria, that is R in AVL plus S in V3 greater than 28, and he's also got the Sokolov-Lyon precordial, that is R, the S wave in V1 or V2 plus the R wave in V5 and V6 greater than or equal to 35. So this is a kind of classic EKG you can see in someone with hypertension. Okay, so let's have a question here. Which of the following is true about left ventricular hypertrophy on ECG? It may indicate underlying thickening of the left ventricular wall. the R wave in AVL is greater than or equal to 11 millimeters tall, it may result from a bicuspid aortic valve and the ventricle going, push it real good, or all are true. Wow, third 100% of the day. Wow, I'm just so impressed with my guardians of the medical galaxy. Thank you all. Good job. Right ventricular hypertrophy. So remember, the right ventricle is sitting, again, underneath V1. Now, normally, because the right ventricle has hardly any muscle thickness compared to the left ventricle, there's a little bit of a upward on V1 from the when the right ventricle goes off, but most of the vector is from the left ventricle because there's a lot more muscle mass. But in these individuals, instead, you are going to have a bigger R wave, because remember, V1 right underneath the right ventricle, positive energy toward a positive electrode causes an upstroke, so they are going to have taller R waves in V1. So the criteria we actually use is if the R wave in V1 absolute value is greater than or equal to 7 millimeters, or if the R over S ratio in V1 is greater than 1. So in other words, if there's more R than S, that's pretty predictive of right ventricular hypertrophy. So here is a 26-year-old female with pulmonary arterial hypertension, and you can see her big juicy R wave in V1 from her right ventricular hypertrophy. Okay, question 30. We've just talked about LVH and RVH. See if you can nail this one with another 100%er, Guardians of the Medical Galaxy. This ECG shows electrical changes consistent with left ventricular hypertrophy. Is that true or false? Take a look. Is this LVH on this ECG true or false? And it's in your book there in case you need to take a look again. Okay, good. Well, I think we're on target for most of it. So let's have a look. This is, in fact, indeed, it is LVH. You do have the R wave. Hopefully, you can see that the R wave in AVL greater than or equal to 11 millimeters. It looks like it's about 16 millimeters there. The R wave in AVL plus the S wave in V3 greater than or equal to 28 for a male or 20 for a female. Either it meets criteria. And then finally, the S V1 or V2 plus R V5 V6, you can see, in fact, that R in V5 is already at about 40 here, is greater than or equal to 35. So this is consistent with left ventricular hypertrophy. Okay, a couple of extra sort of exam ECGs. I found this online, and I saw this L'amour four, and I'm thinking, okay, that must be the diagnosis. So I was looking and I thought, okay, looks like they might have left atrial enlargement. And if this is V1, it might be a IVCD or a right bundle branch block. So I was trying to figure out, might be some sort of congenital heart disease. So I Googled L'amour four, Google translated, and this is crazy love. So I'm hoping that all of you have this ECG or have had it or will have crazy love in the future. Okay, so let's have a look at a couple of cases of exam ECGs. The PR interval is short, and there is slurring of the R wave upstroke. So take a look at this. We may or may not have talked about this condition before, but this is something that often comes up on the board. So what are you guys feeling it? What do you think? Good job, the Wolf. So this is the Wolff-Parkinson-White. Technically, it is the Wolff-Parkinson-White pattern or pre-excitation. And importantly, you've got the delta wave. Yes, sir, I agree. And you have the delta wave, and this pattern. Now, it might be that they go through their whole life with no problems, but they often will run into this AV reentrant tachycardia that we were talking about before, because they've got this extra pathway here which can set up a circuit. So here is the pre-excitation. Here is the actual syndrome. Here, this person developed AFib and are conducting over that pathway. This is really, really problematic because they can get up to really high rates. The heart cannot pump at 300 beats per minute for long. And oftentimes these people will be very symptomatic and collapse, like our lady early on. It's more common in men. Left-sided pathways are the most common. So to manage this, the good news is our EP buddies are exceptionally good at finding this accessory pathway and taking it out. 95% plus success. So this, we don't do it on everyone. We only do it if they're symptomatic or they have a high risk for AFib. So that girl before that came in, we cardioverted, remember? She was symptomatic with Wolff-Parkinson-White syndrome. She would be referred for an ablation. We can use some medications as well if people refuse ablation. But again, ablation is such a good procedure in most cases. So one of the ways, so let's say you found a wolf in your practice and you're like, well, are they going to run into problems or not? You do an echo, maybe it's okay. A great thing you can do is either a Holter or do a exercise ECG in your office. Now, if while their heart rate speeds up, either on your exercise ECG or on the Holter, if they lose conduction over the delta wave, in other words, if they, by priority, utilize their AB node and not use the accessory pathway, that means they are in a very, very low risk. Basically, they will not have problems with that pathway throughout their life. And you don't have to do anything for those, which is a good way to risk stratify them. Remember, as we talked about before, if someone comes in with Wolff-Parkinson-White and AFib, first of all, it's going to be AFib, you can tell AFib because that's irregular. But the thing is, well, do they have a Wolff? Wolves generally will come in very fast, typically 250 to 350 beats per minute. Regular AFibs will come in, 150, 180. So if you see a really fast AFib on the boards, don't check off IV esmolol or IV, DILT, but instead make sure to check off the other medicines. That is, remember the Whipperit, so the ibutylide, the procainamide, or the amiodarone. They will block the accessory pathway, which is what you want to do. Okay, question 31. A 19-year-old presents with 2 episodes of palpitations while playing basketball. He feels fine now. What do you think his ECG shows? So take a look, and it's in your book as well. Do you think he has got an acute STEMI, Wolff-Parkinson-White pattern, anomalous coronary artery, or long QT syndrome? Excellent, Wolff-Parkinson-White pattern, yes. He had the pattern, so hopefully you can see he has the delta wave here. Classically, you can see it very nicely there with the short PR interval. He's got the setup for palpitation. Now, he doesn't have STEMI, there's no ST elevation, so he doesn't have STEMI. He does not have anomalous coronary artery because what's the commonest ECG with anomalous coronary artery? Normal. It's completely normal. We can't use ECG to detect anomalous coronary artery. We've got to use imaging. And his QTC interval is quite okay. You can see you can fit 2 QTCs within the RR. So this is classic Wolff-Parkinson-White syndrome. Okay, this is a 22-year-old end-stage renal disease patient, non-compliant with dialysis. Tall peaked T waves, flattening, widening, loss of the P wave. This is just to teach you that not all peaked T waves are created equal. This is hyperkalemia, and this was one of my records, I think. This is almost 20 millimeters high. You can see here the changes, the different changes. The first are the peak T waves once the potassium hits 5.5, and then you start getting long PR interval, flattening, widening, loss of the P wave. Then you start moving into sine wave territory, and then you can get into some really nasty things. So here is someone with a potassium of 6.8 that was missed, and they were admitted and treated with different nebulizers and things, and then you can see later on they got worse here with a potassium of 8.6, showing that sine wave and the loss of the P wave interval, etc. Okay, this person came in for a pre-participation sports evaluation. And we actually do, as part of our evaluations, we evaluate the Rockets and the Rice University players, and this person had something on his ECG. I'll give you a hint. Number 1, it is bad. Number 2, it is on that list of conditions that I showed you is associated with sudden cardiac death in young athletes. And number 3, big hint, the second word is syndrome. Anyone feeling it? Very good. Brugada syndrome. Very good. This guy actually had classic Brugada syndrome. He had, we referred him for further workup. So with the Brugada syndrome, anyone who has any type of major event, like if they had syncope, or if they had an arrest, or just documented VT on a Holter or something, they require an ICD. That will completely reduce their risk of sudden cardiac death. This is one definitely to know. You may see it on the boards, and the reason is they think it's more common than we think, and about 10% mortality each year undetected. Again, it's autosomal dominant and more common in males. Okay, just a few final comments. To quote Peter Quill, aka Star-Lord, we will, and with my variation, we will not stand by as evil exams wipe out billions of innocent lives. And just a couple of final thoughts for you guys. Just remember, the big rocks in life. You've got your, your family, you've got your religion, you've got your health, you've got your work, you've got, your diet. All of those important things. It's important, the late Stephen Covey talked about this, to get those big things into your bucket, whether it be each day or each week or whatever first. And then, the sand that you pour in later, that's, you're surfing the web, or you're, watching your Netflix marathon or whatever, but get the big rocks in first. That's really important. A couple of quotes there. Be the change you wish to see in the world, from Gandhi. We talked about that earlier. Fate rarely calls upon us at a moment of our choosing. Optimus Prime from Return of the Fallen. Fortitudinus Vincimus, by endurance we conquer. Steve Prefontaine, Sir Ernest Shackleton, by endurance we conquer. Just remember, endure and you will conquer the boards. And to give anything less than your best is to sacrifice the gift. Steve Prefontaine. Try not, do or do not, there is no try. Master Yoda, The Empire Strikes Back. And I was very excited to see TNT is doing the marathon this weekend. It's been excellent. I've been checking in on that. This is a Chinese idiom, wu ji bi fan. This basically means if you do things to extreme in anything in your life, you will get an adverse or you will get just nothing out. So the normal rule of return and effort, we think, goes like this. You put in more effort, more return, and then you get more out. But it actually, what happens is at a certain point, it will plateau off, and then actually further down, you actually get negative return. So it's important, look at that study-wise that Tony has. It's important when you are studying, make sure you are doing other healthy things. Exercising, taking breaks, eating healthy, sleeping properly. Those things are just as important to just going and banging away at it, studying. Seems to me that when I die, these words will be written on my stone, the story of my life, from One Direction. So important, you want to remember what people will remember of you and what you are doing, not only your patients, but others. And I really like this one. This is from the SEALs. There are two wolves who are always fighting. One is darkness and despair. The other is light and hope. And the question is, which wolf will win? The one you feed. And, because we did have the marathon of Star Wars, I'd like to give a couple of Star Wars quotes to end here. From Master Yoda, fear leads to anger. Anger leads to hate. Hate leads to suffering. That's very important. Do not fear, and don't create fear, because it's going to go nowhere. And this one, a bit more positive, from Qui-Gon Jinn, your focus determines your reality. So keep focusing on the positive, feeding the light and hope. Keep telling yourself, I've done the preparation, I've done the work, I will succeed on the boards. So thank you, Guardians of the Medical Galaxy. If you enjoyed my presentation, I'd be honored to have a sweet feedback score on your evaluation. Go forth and crush your medical exams. Dr. Star-Lord out.